Good morning, everyone. Thank you so much for joining us this morning. My name is Brittany Garcia. I'm the program coordinator for the Texas Southern University Baylor College of Medicine P20 Collaborative Union for Cancer Research and Educational Development. Thank you so much for joining us. Today is our summer research program symposium. And so I wanted to start off by introducing the MC for today. Miss Edith is a nurse practitioner with experience in primary care, nursing education, community health, and clinical research. She holds a master's degree in nursing from the University of Texas Health Science Center in Houston, where she is currently pursuing her PhD with a focus on culturally tailored approaches to preventing, managing gestational diabetes in minority women. She holds a bachelor's degree in nursing from Prairie View A&M University with an associate's degree in applied sciences and a licensed vocational nurse certificate from the Houston Community College. Additionally, she earned a bachelor's degree in mathematics in education from the University of Abuja, Nigeria. Sorry. Her commitment to preventative health and research is deeply personal by the loss of her father to diabetes and its complication, and her only sister to the complication of gestational diabetes. Thank you so much, Miss Edith, for being the MC for today. Yes.
Thank you very much, Brittany. Thank you all. Thank you so much for coming around today. It's a pleasure to be here among great minds, among people making all the differences that we need in healthcare. Thank you all for being a part of this. I'm going to be introducing Dr. Rouse. Dr. Rouse? Name's Dr. Rouse. So Dr. Rain Rouse is an associate professor and the director of community engagement, Office of Diversity at Baylor College of Medicine. She serves as a physician on the bone marrow transplant, stem cell transplant program at the Texas Children's Cancer Center. Dr. Rouse is board certified in pediatrics and pediatric hematology and oncology by the American Board of Pediatrics. She spends her clinical time seeing leukemia and lymphoma patients. Dr. Rain Rouse is an avid volunteer serving several years for the Periwinkle Foundation's events and programs for children with cancer and other life-threatening diseases. Her fluency in Spanish has allowed her to provide care to children around Texas as well as in small villages in Bolivia. She is the Baylor College of Medicine Program Director and PI of the TSU-BCM P20 CURED program at Baylor College of Medicine. So she's not here with us today, but we're going to be watching a video from her, and I hope you'll learn from this. Thank you.
Greetings, P20 scholars. We are so very proud of you. As you know, I'm Dr. Rain Rouse, and I have the pleasure and honor of being the principal investigator for the TSU-BCM P20 CURED program from the Baylor College of Medicine side. We are so honored to be here listening to your amazing research. We know that you all have worked so hard throughout the summer, and I will remind you that you were competitively selected from a number of other applicants because you each had something that we believed in. We're very proud of you, and we can't wait to hear about your research. And most importantly, we can't wait to hear all the amazing things that you do in your future. We believe in every single one of you, and this is a really important program, not just for Texas Southern University, but for Baylor College of Medicine. It's always been our goal to partner with other amazing universities and be able to literally have an impact on those who are earlier in their career, but more importantly, you all have an impact on us. We're so very proud of you. I'm so sad that I can't be there today, but duty calls. I am there in spirit, and I can't wait to hear about all the amazing things that y'all have done. As soon as the video comes out, I will be ready. Everyone at Baylor College of Medicine would be there if they could, but I'm very fortunate that we have a few folks who are in leadership positions who will be there to say hi to you and say how proud they are as well. Thank you so very much. Thank you to the Baylor College of Medicine and Dan L. Duncan Comprehensive Cancer Center leadership. Thank you to my wonderful co-PI, Dr. Veronica Ajewole. Thank you to the CURED C-Rep leaders who have worked so tirelessly throughout all of this. And most importantly, thank you to all of you, your mentors, your friends, family, and loved ones. I know they are so very proud of you. Have an amazing day. You've already won. Bye.
All right, that is awesome. That is awesome. Thank you, Dr. Rouse from the distance. All right, thank you. So the next will be Dr. Veronica Ajewole. She is a phenomenal leader, I must say. Dr. Ajewole is a phenomenal person. Her leadership skills honestly need to be studied in Harvard. Okay? So if you don't know her, you're about to meet her. Now, Dr. Ajewole Wemmer serves as a professor at TSU and a clinical pharmacist and an adjunct assistant professor of oncology at Houston Methodist Hospital. She received her PharmD from TSU and completed her oncology pharmacy residency at Houston Methodist. She is a board-certified oncology pharmacist with clinical practice in oral chemotherapy at Houston Methodist Hospital Cancer Center. She also serves as the Assistant Vice President for Clinical Translational Research and Community Engagement at Texas Southern University. She is the TSU Program Director and PI of the TSU-BCM P20 CURED program at BCM. Ladies and gentlemen, please, with a round of applause, let us welcome our phenomenal Dr. Veronica Wemmer Ajewole Wemmer. I'm still trying to get used to that, okay? Thank you so much, Doctor.
Thank you very much, Edith. Edith is going to create that Harvard curriculum, right? And get it approved. Thank you very much, Edith. And good morning, everyone. How are we all doing today? Good, excited. I am really, really privileged, and I feel very honored and humbled, to have the opportunity to stand here in front of each and every one of you amazing scholars this morning. It has been a pleasure of myself and Dr. Rain Rouse, to have been able to lead the implementation of this program. We do not take it for granted, and every time they read this bio, I'm like, God, to you alone be the glory. I am just a yielded servant doing what God has laid on my heart. So we are really excited to have you all join us in person, mostly. And for those that are also online, you are welcome. And over the next few minutes, I will go over just a quick overview of what the program P20 CURED is about. Like you can imagine, the P20 CURED program is an intentional collaboration between Texas Southern University and Baylor College of Medicine. Even though TSU and Baylor are just a few miles apart, they are, definitely very different institutions. And on this slide, you see the faces of the amazing leaders. I don't do it alone. I do it alongside amazing leaders, Dr. Liang, Dr. Jay, Dr. Onta, Dr. Ogbo, Dr. Solitaire, Dr. Jeffrey Lowe, Brittany Garcia over there, Cassie, Shamais, all these people from Texas Southern University, as well as from Baylor. You just heard from Dr. Rain Rouse, who will miss her presence here this morning because she is at another conference. Then we have Dr. Arun, we have Dr. Shisha, who you're going to hear from later. We have Dr. Murray, Dr. Benny, we have Jasmine, as well as Dr. Reddy. Please help me to appreciate the amazing leadership of these individuals who have been able to successfully implement this project. So in between all that we do, alongside these leaders, our P20 CURED program has 4 major components. One of the components is about, community outreach and engagement, as well as training for the scholars, which you guys are under. So that is what we call the CREP. Additionally, we also support pilot projects led by early-stage investigators. Some of you guys were paired with some of these early-stage investigators over the past 8 weeks. And additionally, we also established an administrative core because, like you can imagine, there's a lot of administration that needs to happen in between the two institutions. So this is just, a slide showing the integration of how the programs are integrated together. Then we work alongside amazing leaders in between both institutions. Some of our leaders are here this morning. I will be introducing them shortly, but we have Dean Mosavin, Dr. Olale, Dr. Michelle Penn-Marshall from TSU, as well as Dr. Eslop from Baylor College of Medicine. Not only that, we also have an internal advisory committee. What does that mean? We are accountable, both internally and externally. And with that, we have Dr. Olale, Dr. Lau, Dr. Poon from TSU, as well as Dr. Rowley, Dr. Oder, and Dr. Moreno from Baylor College of Medicine. Also, with us being funded from NCI, NCI is the National Cancer Institute under NIH, which is the National Institute for Health. We have an external advisory committee that also ensures that we are keeping up with what we promise the government that we are going to deliver. And we have, amazing leaders from across the nation who are providing oversight to the program that we implement. Dr. Openda, Dr. Betty, Dr. Lona McNeil, Dr. Ford, as well as Dr. Kuma. So we are really blessed, right, to have, such an amazing infrastructure to support the programs that we do. Again, this is just showing us how our cores are integrated together alongside with faculty mentor and all the different cores that we have. And now I want to, give a quick highlight of how these scholars were selected. Typically, in late fall, we start, promoting recruitment for scholar identification. This time around, we had 70 applicants. All right, just imagine like 70 people were interested in participating in this program. Out of those 70 applicants, these 16 scholars were competitively selected. Please give yourselves a round of applause. You should be so proud, you should be so excited that you had that privilege to be part of this cohort. Over the past 8 weeks, these scholars had the opportunity to engage in an 8-week-long experience, which included being matched with mentors at Baylor College of Medicine. Some of them had in-lab experience. Some of them had they all had advanced technology core experiences where they actually did clinical research and benchtop-based research at Baylor College of Medicine. Not only that, we also make sure that all the scholars had an opportunity to engage with the community, with community engagement and outreach. Please, once again, give yourselves a round of applause for the successful completion of your program. And I also want to thank your parents, your family members, and your loved ones who supported you throughout this journey. So what are we here to do today? We are here to listen to an overview of the research that each of these scholars participated in. Each of them have put together an amazing presentation that will run for about 7 minutes, and then we'll have an opportunity to take questions. And we also have people joining us online on Zoom as well as on YouTube. That brings me to the end of the overview for the CURED program. And now I will bring up greetings from leaders from both Texas Southern University and Baylor College of Medicine. The first leader that I want to bring up is no one else but our very own Vice President for Research and Innovation here at Texas Southern University. Dr. Michelle Penn-Marshall is the inaugural VP for Research and Innovation, and DRI was established in 2022, and since its inception, the research expenditure has increased by 32.8%, with fund requested by 90% and funding received increased by 80%. Dr. Penn-Marshall received a BA in Scientific Curriculum and MS in Biology with a concentration in Environmental Science from Upton University. She received a PhD in Community Nutrition from the Department of Human Nutrition, Food, and Exercise at Virginia Tech. Dr. Penn-Marshall is the PI of the U.S. Department of Education, Research and Development Infrastructure entitled path to R1 at TSU, which is a $4.99 million award. She is also leading the Catalyst for Urban Transformation, a $40 million project that will create a research and innovation nexus for faculty, students, and community members to address urban American grave challenges. Without further ado, please welcome up stage Dr. Michelle Penn-Marshall. Thank you.
Thank you so much. It is such a pleasure and an honor to be here. I get to see the work that this team does, and Dr. Ajawale, I don't know if it's 11 or 14, it's some number past 10 of grants that she actually has. So to lead that many grants, it's great to get them, but executing them is where the real work comes in. And her heart is for the community. Her heart is for the students, and the same thing for Dr. Rouse, who couldn't be here today. Had the pleasure of working with them. But I'm standing before you to just greet you briefly on behalf of President Crawford. He is the President James W. Crawford III, let me get that right. He is the 14th president of Texas Southern University, and also Provost Goodman. They both believe in research, they believe in innovation, and they are student-oriented. So the work that you all have done this summer does not go unnoticed. It's not unheard, it's not unread. Provost Goodman just sent Dr. Ajawale a personal letter congratulating her on the $2 million that she received for CPRIT again. So you've worked all summer. I have some words that I have written that sound very eloquent, but I'm going to speak from my heart. The 8 weeks that you have been here, I know are intense. The opportunity to be able to work at Texas Southern and your Texas Southern students and Baylor College of Medicine is unprecedented. There are many people, there were 70, they chose 16. There were many people that did not have that opportunity and luxury. And the fact that you're studying such an important subject, cancer, cancer prevention, cancer education, how do we eradicate, that's always my goal, to eradicate diseases from our community members, our family members. So thank you for spending your time this summer studying, researching, understanding the research process. You will be able to apply that to everything you do. I know we have undergraduate students. I met our graduate student here, who is a second year now pharmacy, a PhD student in pharmacy, and he came here from Purdue, where my parents met. They met at Purdue University in Indiana. So just to know your background and the family members who are online, the other researchers and leaders who are online, this could not be done without mentors. They have other things to do, but they have chosen to invest their time, their talent, and their interest in you, because you are the generation that's going to take us where we really want to be. So I want to welcome you. I really wish I could be here. I love to stay and hear the presentations and ask questions, but we are working on the catalyst. I left the architects to run over here. We want those buildings to be something that's representative of you 20 years from now, 30 years from now, so that you continue to be a TSU proud alum. Thank you very much, and it's a pleasure.
Thank you very much, VP. Thank you, thank you. We are really grateful for VP's amazing leadership. She leads and she does it almost effortlessly. We really appreciate your support. The next leader that I'm really excited to bring up stage is my personal mentor. I call her my catalyst. She tells me, Veronica, don't say that, but hey. So the back end of the story is when I was a student here in TSU in my first year in pharmacy school, that was where I met Dr. Laleye. I started in Dr. Laleye's lab doing wet lab research. So when I say evidence of true mentorship, this is us right here. Over a decade long of mentorship and guidance. But Dr. Laleye, I am really excited to have you support us in this initiative, and I'm really excited to bring you up stage. Dr. Monique Laleye is the Senior Associate Vice President for Research and Innovation and a professor of pharmacology at Texas Southern University. She has a strong background and expertise in biomedical research and public health, spanning over a combined 21 years, working on research programs focused on diseases that disproportionately affect the community. Dr. Olaleye was a 2023-2024 ACE Fellow working with the Chancellor of the University of Texas System. Presently, she leads the $8.63 million NIH-funded CBMHR. Recently, Dr. Olaleye also received an ASA grant, $2.4 million, to support and establish maternal health research center at TSU. Under her supervision, TSU's drug discovery research experienced tremendous growth, including the development of several advanced research infrastructure and core facilities, state-of-the-art instrumentation equipment, increased grant and contract funding, as well as expenditure, synergy of community engagement, infrastructure and resources, and strengthening of strategic partnership. Please help me to welcome upstage Dr. Esther Olaleye. Thank you.
Wow. Can we just give it up for God? For those of us, I was going to start by saying praise the Lord, and I'm good to say that today marks my 17th academic year at Texas Southern University. I'm entering my 18th year. Today was the day I got the keys to my office. I feel so blessed to be here, but you are more blessed. You are more blessed to be standing on the shoulders of leaders like Dr. Ajewale, Dr. Rouse, Dr. Ogbo, Dr. Edith, all those leaders that are here. Brittany, holding your hands through this. When I was in your shoes a few, I don't know how many years ago, but I had the opportunity to be in a room like this, working, I think, with Merck Research Labs, looking for new medicines to cure all those diseases that we don't have medicines that impact our populations in this country in 2025, right? A lady stood speaking in front of me, and she was telling the scholars, we were young scholars, and she said one thing that stood out to me. She said, anything you find your hand to do it extremely well. Whenever you have an opportunity to present extremely well, like your 90-second elevator speech, because somebody in this room may be waiting to sponsor your next level. The one word I have for you today, you're destined for greatness. You saw how competitive this program was. You should see how hard Dr. Ajewale and Dr. Rouse and their team worked really hard to actually get this grant. They're the only one in the whole country that received this grant in that cycle. So you guys are super blessed, but there's a high expectation on you. There's a really high expectation on you to transform our communities. The world is waiting for what you're going to do next. And that's what I want to leave you with. So as we listen to your presentations, your research, cool science is great, but at the end of the day, we want to transform our communities, and nobody else will do it for us. We've been on it for years. We're not where we want to be, but we're not where we started from. We're standing on the shoulders of others that have gone ahead of us, and they did their part, and you are asked to do your part today. So take these presentations very seriously. Take this journey very seriously. And when you complete this program, don't burn bridges, because the whole world is waiting on you. When you step out of this campus, you're going to see the community hopeless, very poor health outcomes. Nobody from DC or any other country is going to come and rescue them. But your work that you're doing every day, it adds up every day. Somebody may say, Doctor, what are you talking about? Every single thing you do adds up every day. And by God's grace, with us, VP Dr. John, give it up for my boss over here, please. She's an amazing leader. And Dr. Ajewale and her team, everything we do daily, we do it with excellence. We may never get to be in front of everybody, but the greatest thing is we know we will get a reward. But more importantly, know that that man, that woman that's dying of prostate cancer, breast cancer, dying of giving birth as a Black mother in this country. You know the crisis. They're all waiting on your work. So don't let anybody play you small and say, oh, you're just doing that. It's just one more thing on your resume. You're standing on big shoulders and you have a cloud of witnesses, your family members, waiting on you for that excellence. And we believe in you is why we brought you here. So go forth and shine. Thank you. Give it up for yourselves.
Thank you very much, Dr. O. We are really, really blessed to have you. I mean, scholars, you guys are fully motivated, right? You see, I told you, catalyst effect. In between Dr. Olalaye, catalyst, VP, amazing support. You guys have no choice but to shine, right? You have no choice but to excel. I am really, really delighted. I think the third leader is from Baylor College of Medicine. Is she around? Oh, awesome. Yay, I'm glad you're here. All right, let me read your bio, Dr. Greeley. So Dr. Bambi Greeley she has worked in clinical research for over 25 years. She has experience as an investigational drug pharmacist, IRB administrator, IRB member, regulatory affairs professional, and in conduct of clinical trials. She has always worked in oncology, and in addition to that, has worked in cell and gene therapy protocol for over 15 years. Ms. Greeley provides in-depth regulatory guidance to investigators developing projects involving translational product and assists in the regulatory affairs and clinical research extensively, both within Baylor College of Medicine and internationally. She has overseen the regulatory submission of over 1,500 clinical research studies, almost half of which are therapeutic. She has assisted in the submission of over 70 investigator-initiated INDs with over 110 studies conducted under them. She has prepared and implemented over 100 standard operating procedures for clinical research and has established quality assurance and quality control programs for the protocol being conducted under her purview. She has developed data review processes for internally initiated studies, including the establishment of data safety monitoring boards for a select group of studies. Without further ado, please join me in welcoming Dr. Greeley upstage for institutional welcome. Thank you so much. We are really, really delighted to have you. Thank you.
Good morning. Yes, thank you. I'm representing Baylor College of Medicine. I'm representing Pavan Reddy and Helen Heslop, who couldn't be here. Sadly for you, I'm also representing Dr. Rouse, who is a lot more fun than I am. I know you know that. So sorry, it's me. But I'm really here. Rain actually wanted me to talk to you because I actually want to express how deeply I feel about programs like this and people like you, and how much I want to encourage you to not feel limited by anything. I'm a Bachelor of Science in Pharmacy. So all this stuff that I've done is not because I went to school forever and became a MD, PhD, whatever, right? I did this through passion, through love, through a desire to make a difference. And when you're one of 16 people in a program, you're already there. You're already there. You just need to keep that passion going. So whether what you did this summer is wet lab, dry lab, administrative, whether you loved it, which is great, or didn't, which is informative, and I want you to be clear that even if you didn't like what you did, or even if there's stuff that you're like, this really isn't my thing, that's okay. Because what you're getting here is a chance to learn what you do want to do and how you do want to make a difference. I am a pharmacist by training. I worked as a pharmacist at MD Anderson for 10 years. I loved it at the time. I liked dealing with the patients. I liked going in their rooms. And then there was a point where I just couldn't handle it anymore. I mean, this work is hard, right? And I have served, this slide is so out of date now. I have served in administrative roles basically for 30 years now. And I feel as relevant as if I was seeing patients, because what I do is support physicians and support researchers to make sure that they're not wasting their time doing paperwork that I can do. And, you know, people like Rain take me in the room to meet some of the patients whose lives I impact. And that's enough for me. I just want to see whether it's a good outcome or a bad outcome. I just want to make sure that I'm making a difference in this field to push it forward. And you guys can really do that. I mean, you're in this room because you're something special. And that discussion of how hard Rain and the other PIs on this grant worked. I can't emphasize enough how competitive that grant was, how hard it was, how much time goes into writing a grant. And they really believed in it, and they really believe in you. And I guess I had something I really wanted to say that obviously I forgot while I was jabbering away. I just want to emphasize that we're at such a turning point. When I got into pharmacy and oncology, all we had in our tool chest was chemotherapy. And I want you to think about that a little bit. Taxol wasn't even approved when I started. So in my lifetime, we have changed therapy so much. I obviously work in cell and gene therapy. I obviously believe in cell and gene therapy. More importantly, I think that these treatments are transformative. These are treatments that can take a patient from having full-blown end-stage disease to cured. And we have a patient who had neuroblastoma, which I'm sure you know has a bad outcome, who's 20 years out right now from our treatment, right? So yeah, it's one patient, but you know what? It's somebody who really matters to them, right? All of this to say, the problem with cell and gene therapy and a lot of the treatments we have right now, and I know you know this, is cost and access. And we don't have the proper cost structure, and we definitely don't have the proper access. And I know that a lot of this discussion has been around urban, but I can't even tell you how difficult it is to get proper treatment in rural America, let alone other countries. I'm very involved internationally. I believe firmly that we have one of the best healthcare systems in the world. But even here it's very stratified, but you go to other countries, it's really ridiculous what's going on out there. I think that there's no excuse for us not having proper access to medications for all patients, all places. I hope that as we move therapies forward, as you get involved in this, however you get involved in this, that you keep that in mind, that this access issue is equally as important as what gets developed in the labs. We have to make a difference. We have to do the next steps. And so as I heard the other speakers talking about, you're on the shoulders of others, you're pushing into the next generation, you're making a difference. I think that the stuff I'm talking about right now wasn't even in a thought when I was working at Anderson, right? It's like these patients come in, this is who we treat. We've got to get past that. We've got to get past, like, can you make it to Anderson? Can you make it to Baylor? What happens if you live in rural Kentucky, rural Tennessee, rural Texas even, right? What happens if you can't make it away from your family long enough to stay someplace and get treated? And we just got to do better. And I know you can do it. But again, regardless of whether you get involved in access or developing cures or whatever you do, I hope that this summer was helpful to you. I hope it really motivated you, and I hope you had fun, because at the end of the day, this is a fun field. You make a difference for people, and that's a good feeling to have at the end of the day. So congratulations to all of you. And again, I apologize that I'm not Rain, because she would have just torn it up here.
Awesome. Thank you very, very much for your, really inspiring words. Our background is definitely very inspiring. I'm a pharmacist by training myself in oncology. So definitely a lot of great connection and inspiration there. But thank you all our institutional leaders from Baylor College of Medicine and Texas Southern University. We are truly delighted to have support from great leadership from both institutions. Without further ado, we would move on into the podium presentations. So scholars, it's okay. Take a deep breath. You guys are going to do amazing, okay? Breathe in, out. You're going to do great. Like you already have on your agenda in the booklet in front of you, the podium presentation is broken into 4 segments, and you would have a moderator for each segment. If you look right behind over there, that's a timer that would have a countdown clock. So please pay attention to that, so that way we help to stay on track with your presentations. Okay, I will bring up stage the moderator for the first segment of these podium presentations. This is no one else but Dr. Nkechi Ogbo, who is also a pharmacist. Dr. Ogbo graduated with a Doctor of Pharmacy degree from the University of Minnesota Duluth and completed a 1-year general practice residency at the Michael E. DeBakey VA Medical Center here in Houston, Texas. She also completed a master's degree in public health with an emphasis on public health leadership from the University of North Texas Health Center in Fort Worth, Texas. Over the past 16 years, Dr. Ogo has worked in retail setting and pediatric hospital setting before joining TSU as the health education and community engagement pharmacist in late February 2024, where she supports all health education advancements, research, and training initiatives, including the Breast Cancer Screening and Prevention Center. Please join me in welcoming no one else but Dr. Nkechi Obo. Thank you very much. I appreciate you, Dr. Obo.
Thank you, and thank you all for being here. Thank you to the families of our students who have made time out to be here today. We really appreciate you all. So just quick disclaimer for everybody. For the students presenting today, please realize that you are the experts in this room. So please let go of any kind of intimidation. You are the experts in this room. I wouldn't know if you are blubbering, but I'll believe you. So please just be comfortable with this. And without further ado, I have the pleasure of introducing the first presenter. Elmira is a Doctor of Pharmacy student at Texas Southern University, and her research interests include clinical research, pharmacotherapy, and patient-centered care. She's passionate about exploring how clinical studies can improve therapeutic outcomes and enhance healthcare practices. Elmira's career goals are to contribute to clinical research initiatives to advance evidence-based medicine and ultimately improve patient health on a larger scale. Amen to that. She aspires to work in clinical trial development and research. I think that is it. So I guess she can probably finish up her bio. Come ahead, Elmira. Thank you. Please, can you give her a warm welcome and encourage her?
Good morning, everyone. I'm going to present today about my project. I'm very privileged about working in Baylor College of Medicine and with the mentorship of Dr. Sarah Elsia in the Department of Molecular and Human Genetics. This project bridges clinical care with genomic science, and I will provide information about that for you. At Baylor College of Medicine, the genetic team analyzes patient DNA to detect pharmacogenomics markers, genetic variants that influences how drugs are metabolized. Physicians align this data with patients' clinical profile. My role as a future pharmacist is to help integrate the information into medication management, ensuring therapy is tailored to each person's genetic. The goal is to improve treatment outcomes, reduce side effects, and promote medication safety. As we see here in our slide, the implementation process in clinical pharmacy that we are working is stand on the genetic test result that we getting completed through the medication therapy and clinical review. This includes the evaluation any polypharmacy risk based on the drug-gene interaction. We tailor therapy recommendation and collaborate with the providers to finalize the treatment plan, and also we are patient education. That is a very important key role that explain how their genetic influence their medication. For this work, we use the structure that apply as Navigate framework. It stands for need, alternatives, validation, availability, gene-drug interaction, and therapy tailoring and EMR documentation. These frameworks help pharmacists interpret PGX data and ensures that clinical recommendations are well supported and patient-centered. Many of top prescribed medication, particularly in Medicare and Medicaid populations, have pharmacogenomic guidance. Supported by CPIC, the Clinical Pharmacogenomics Implementation Consortium. CPIC is an international collaboration between clinicians, researchers, and pharmacists that develops peer-reviewed, evidence-based guidelines to help providers interpret genetic test results and apply them to prescribing decisions. These guidelines translate genetic data into specific clinical actions, such as whether to adjust the dose, avoid a drug, or monitor closely. Commonly affected medication includes warfarin, statins, antidepressants, and some opioids, all frequently used in aging population where polypharmacy and unpredictable drug responses are major concerns. Implanting the PGX reduces trial and error prescribing, improves adherence, and helps avoid preventable adverse drug events. Even now, FDA support direct-to-customer PGX testing, emphasizing the growing clinical and regulatory acceptance of using genetic information of routine care. Pharmacists are uniquely trained to lead PGX implementation. Each year, over 1.5 million preventable adverse drug events occur, costing over $177 billion. PGX allows us to reduce those events by aligning medication to a patient's unique biology. As shown in the diagram, both genes and environment, such as diet, comorbidities, and drug interactions, affects how medication work. PGX helps us bring all those factors together to have safer medication. Cytochrome P450 enzymes like CYP2D6 and CYP2C19 are major players in drug metabolism. Variants in these genes influence how quickly or slowly a drug is broken down. These can lead to toxicity if the drug accumulates or treatment failure. It is not cleared too quickly. Knowing this ahead of time allows us to prescribe safer medications. Warfarin dosing depends not only on metabolism, but also on the VKO-RC1 gene that encodes its drug target. Patients with certain VKO-RC1 variants may be more sensitive or resistant to warfarin. Without PGX guidance, these patients may experience serious bleeding or clotting complications. Oh, sorry. The SLCO1B1 gene affects statin transport into the liver. Variants here increase the risk of statin-induced muscle pain or myopathy, especially within simvastatin. Identifying these variants helps providers choose alternative statin or adjust the dose. SSRIs such as fluoxetine and escitalopram are widely used for depression and anxiety. Variation in CYP2D6 and CYP2C19 explain why some patients get side effects while others doesn't respond at all. PGX can guide initial selection and dosing of psychiatric medication, avoiding delays and achieving relief. On the other hand, we have CYP6PD deficiency is more common in certain ethnic population. It predisposes patients to hemolysis. When exposed to certain medication like sulfonamide and anti-malaria, knowing a patient's G6PD status is a key PGX safety measure and is especially important in global or diverse care setting. so far? I've completed the literature review, finalized the PGX workflow using the Navigate model, and begun developing patient and pharmacist education materials. I've also worked closely with BCM's genetic core to align clinical applications. Next, we will pilot the PGX workflow in selected ambulatory clinic, develop EMR documentation tool, and began collecting outcome data. The vision is to create a scalable model for pharmacist-led PGX integration that supports personalized care across many clinical settings. So in the conclusion, the project highlights how CPIC-guided pharmacogenomics can improve medication safety and outcomes, especially in aging population, by identifying how genes influences drug metabolism. In response, we can move away from one-size-fits prescribing for all. Pharmacists uniquely positioned in this leadership to transforming by integrating PGX into routine medication therapy and have less side effects and more efficacious medication for every person according to gene background. Thank you. I'm here and I'm so happy that answer any question that you have. Also, I want to really appreciate the Baylor College of Medicine mentors that I have there, Dr. Sarah Elsia and her team, and Texas Southern University, Dr. Rose, Dr. Ajewale. I cannot say how happy I am that I'm standing here and talking to you. If wouldn't be under your mentorship, I never could be do any of these things. I appreciate you.
So any questions for her? Anyone? Hold on, please. Wait. Because we have those online. So
Okay, yes. So what was your favorite part of your project?
Actually, I believe that the chemical medications that it's like years we are using to cure many disease states are not the only key that can be effective for helping people to get rid of those disease stages. I believe that DNA, like gene, can be the most effective therapy way that can help many disease stages, especially cancer, from top to bottom, like any kind of disease. We can work to solve those diseases without needing chemical medications.
thank you for your answer. Anyone else? We good? Okay, Dr. A.
All right, I'm good now. I have a comment for you, Elmira. I just want to tell you how proud I am of Elmira.
Oh, thank you so much.
You know, she was that student who, when she realized that when I was in pharmacy school, I had children, I was married with kids with Dr. Laleye knows. And the moment she knew that, she walked up to me and said, Dr. Ajewale, please mentor me. How do you do this with your young children? I mean, our passion is just, it's enlightening to see a student like you and see you grow. And I'm not surprised at all that your mentor, Dr. Elsie, has extended an offer for you to continue doing your work at Baylor. We are so proud of you, we support you, and I look forward to the greatness that is ahead of you, as well as of all the scholars that we have in the room. So kudos to you, and looking forward to the future.
I appreciate it.
Awesome. Thank you, Amira. And if I might add, since I'm holding the microphone, right? My own turn, pharmacy school. Let me be very blunt and honest. I ran away. Like, I just crammed everything for the cancer part, and I left. I'm like, oh no, this is too scary. But let's say I'd had somebody like Dr. A, maybe who wrote a P20 grant, maybe I might have had interest in it. Now, years later, as a pharmacist, when I was doing chemos and stuff, you know, verifying orders, I'm like, this is not as bad as it seemed in pharmacy school, but and that is what you get. So we are really grateful for the opportunity. Thank you again to Dr. Rouse and Dr. Ajewale for writing this grant. All right, next person here is Olivia Williams, and she is a community clinical psychology graduate student at TSU. Her research interests include the correlation between medical diagnosis and mental health disorders. We need this, we need this, we need this. So thank you, Olivia, for this. Specifically, the impact cancer has on the body and mind. Now, Olivia's career goals are to address health disparities in underserved communities and bridge psychology and biomedical sciences. I'm going to say again, amen, without being too cliche. Thank you. Come on ahead. Appreciate you all.
Good morning, everyone. My name is Olivia Williams, and I'm a second-year Master's of Psychology student here at Texas Southern University. This summer, I had the pleasure of working under the mentorship of Dr. Austin Brown, evaluating metabolites associated with depressive symptoms in a cohort of pediatric patients with acute lymphoblastic leukemia. Acute lymphoblastic leukemia is the most common type of childhood cancer in the United States. Thanks to advancements in treatment, there is an increased 5-year survival rate exceeding 90%. Despite this progress, 80% of patients also suffer from a psychiatric disorder, with depression being the most common. In order to understand the molecular mechanisms underlying depressive symptoms, this study evaluated cerebrospinal fluid, or CSF metabolites, associated with depressive symptoms reported during ALL treatment. Patients eligible for this study included those between the ages of 7 and 19 years old, newly diagnosed with ALL, and being treated at Texas Children's Hospital between the years of 2012 and 2018. Patients completed the Childhood Depression Inventory, or CDI, during the start of delayed intensification therapy. This time frame was chosen because it is the most important and intense phase of treatment where you would expect depressive symptoms to be most elevated in this population. After the CDI was completed, standardized total scores were calculated. CSF samples were collected within 1 week of completing the CDI, and linear regression was used to evaluate the association between CSF metabolites and depressive symptom scores, controlling for age, BMI Z-score, sex, race, ethnicity, induction intensity, and metabolic profiling batch. Statistical significance was defined at a Benjamin-Hochberg false discovery, or BHFDR rate threshold of P is less than 0.05. There were 92 patients included in the final sample. There was an average age of 12. 54.3% were male, 56.5% were normal weight, 64.1% were Hispanic, and 48.9% were in a very high-risk group. The depression scores range from 40 to 90, with the mean of 50 and the standard deviation of 8.7. These scores are what you would expect in a general population. However, there were a number of patients that had depression scores close to the 80 to 90 range, which would be considered statistically significant for elevated depressive symptoms. There were 260 metabolites detected in the untargeted metabolomic profiling of CSF samples, and 3 metabolites were significantly higher in individuals with elevated depressive symptoms. We have mannose with the standardized beta of 4.15 and a BHFDR of 0.004, pyruvate with the standardized beta of 3.73 and a BHFDR of 0.01, excuse me, and mannose with the standardized beta of 3.49 and a BHFDR of 0.03. This plot shows the strength of the relationship between each metabolite and depressive symptoms and shows how statistically significant they are. So the higher the point, the more significant it is. The blue dots represent metabolites that were statistically significant after corrections for multiple comparisons were made. And the green dots are metabolites that were statistically significant without the corrections made. Even though fructose and glucose didn't meet the threshold for statistical significance, they are still both carbohydrates involved in the energy metabolism, along with mannose, pyruvate, and mannose, which gives further evidence that there might be an interruption in the energy metabolism affecting depressive symptoms in this particular ALL population. If there is a metabolite to the left of the dotted line at 0, it means that there are higher depressive symptoms associated with lower levels of the metabolite, and if it is to the right of the line, it means that there are higher depressive symptoms associated with higher levels of the metabolite, which is true for the top metabolites that we found. This is an overview of enriched metabolite sets. We have the top 25 pathways on the y-axis and the p-value on the x-axis. So the further to the right, the more significant a result is. The color of each dot also reflects the p-value. So the brighter the color, the stronger the significance. And the size of each dot shows how enriched the pathway is. So the bigger the dot, the greater the enrichment, meaning the group is likely playing an important biological role in the metabolism. This network view takes the same pathways from the previous plot and shows how they're interconnected with each other in the metabolism. Many of the top pathways, which are starred, are interconnected, which is something you like to see in metabolomics because it signifies that the changes aren't random and the significant results are part of a common biological process. As most ALL patients achieve long-term survival, research efforts are focused on improving health-related quality of life in patients. 3 carbohydrates positively correlated with CDI scores, which is consistent with previous research linking energy-related metabolites with depressive symptoms. These implicated pathways could serve as biomarkers or novel therapeutic targets to mitigate depressive symptoms in patients. And I would just like to say thank you to the entire P20 team and a huge thank you to my mentor, Dr. Austin Brown, Ms. Tiffany Chambers, my bench mentor, and Ms. Emily Mason, who is the research assistant of the lab and an overall big help.
Questions? Questions from Ms. Williams?
Olivia, you did an amazing job, and I just want to shed light to know that within cancer care, mental health is often forgotten, right? You remember every time we met on office hours, I will always say you are doing something that is really significant to where we are so engrossed into taking care of patients because of their disease that sometimes we forget their mental health and the mental health of their caregivers. So thank you for engaging in this really important work, because once you treat the patient and they are gone, they remain with their mental health forever. So your work is really important, it's very critical, and we are really proud of you. Good job.
Thank
you. Awesome. And can I just give you a plug? I'm looking forward to reading papers on this, Williams, okay? Thank you. All right. Last but not the least for this session is Ms. Kimura, and she's a junior majoring in chemistry at TSU. Her research interest includes endocrinology and cancer research. Her career goals are to go to medical school, amen, for you, and become a doctor in pediatrics and research on the pancreas in the laboratory. All right, go ahead. Thank you. Can you give her a warm welcome, please? It's not easy.
Good morning, everyone. My name is Kimura Diggs. I'm a chemistry major. I'm a rising senior. And then also to kind of add to what she was saying, doing endocrinology is very near and dear. It's very near and dear to my heart because at the age of 8, I was diagnosed with type 1 diabetes. So it's the thing that really pushes me and drives me to go to medical school. But my project is C-June and AEL-CREM overexpression improves baseline cytotoxic function of GD2 CAR T cells. Before we move any further, as you can see, this is T cell dysfunction limits therapeutic T cell efficacy in solid tumors. And so these T cells are not functioning in the way that they have been programmed to function, which is to fight off foreign invaders or infections in the body. So as you can see on the left side, the graph that shows the acute infection and the vaccination, you have these naive T cells, the effector T cells, which then become these memory T cells, so that when being re-exposed again to these foreign infections and diseases, it would be able to act and respond quickly when you're exposed again, versus the immune system that has chronic infection and cancer. You have these naive T cells, the effector T cells, but then the T cells become dysfunctional. Sorry. Because there is this rapid increase of proliferation of these cancer cells. and that causes a reduced proliferation and cytotoxicity of these T cells. And so we have the baseline, the basic leucine zipper, which is BZIP, or their transcription factors with roles in regulation of T cell states. So we wanted to look at June, BATF2, and CRIM. But within our lab, we use AEL CRIM, which is a synthetic or engineered version of the CRIM that is produced naturally in the body. And we wanted to look at these 3 different transcription factors so that we can better improve the production of the cytokines in the body so that we can have a better outcome of these T cells fighting and killing off these cancer and tumor cells. And so the methods that we use, we have the in vitro repeat tumor cell stimulation assay, where we expose the CAR T cells, which are the engineered T cells, to tumor cells to stimulate this constant attack. And then we use the intracellular flow cytometry. We first started with surface staining, and so in the surface staining, you have these labeled cell proteins, which is where the antigen is conjugating to the fluorescence dye so that it can correspond to its target antigen within the cell. Then you have the fixing, which is where the cells were being stabilized. You have the permeabilization, which is where there's temporary pores being created within the cell so that the antibody can go into the cell and bind to the cell. And then you have the staining, or the intracellular staining, which is where we had these cells going into, it allowed for the cell to go in to the actual cell so that it can bind again to the target intracellular targets. And so for our results, we have CAR-June and CAR-AEL CRIM, improved cytokine production. And so as you can see on the left side, you have the interferon gamma and IL-2. These are cytokines. And we have our control condition, the CAR-NGFR, and the AEL CRIM and the CAR-June and the other 5 conditions. AEL CRIM and CAR-June, they had a greater, they were most promising at helping the cytokine, at producing more cytokine so that these T cells can have a better result at fighting off these tumor cells. That's the goal. That was the goal of this experiment. And then we also have TNF on the right side. This was another cytokine that was used, which also showed AEL CRIM and CAR-June increasing the production of this TNF so that we can fight off, again, these tumor cells and these cancer cells. And this was all done after a 5-hour tumor cell stimulation. And then this is CAR-June, CAR-AEL CRIM, increasing the production of perforin and granzyme B. And so perforin is where these pockets or pores are created temporarily within the cell, and that allows the granzyme B, which is the enzyme, to go in and bind to the cell so that the AEL CRIM and the CAR-June can do their job at helping the CAR T cells. And this is also done after a 5-hour stimulation as well. And then if you are wondering what these bars are at the top with the stars, this just showed like the standard deviation and the significance of these conditions. And so in conclusion, we concluded that the CAR-AEL CRIM and the CAR-June overexpression increased the baseline expression for the cytotoxic markers. For future work, because this was day 0, it wasn't the complete experiment, but it was part of it. We are going to test after 3 rounds of tumor cell stimulation to see the differences in these cytotoxic markers expression under T cell dysfunction conditions. And then I also want to give a warm thank you to everyone that contributed to my success here between Baylor and Texas Southern University. So, also, and my mentors as well, Glenna Foy and Joshua Malroy.
voice. Any questions for her, please? Okay, it's working now. Yes, go ahead. Cassie's right behind you.
Okay. Would you say that you want to do work like this again in the future for your career?
I do. I really do. After doing this experiment with my mentors, I want to expand beyond just doing endocrinology. I also want to do oncology as well. I don't know how that's going to work, combining the two, but I do think it's possible by God's grace. I'll be able to combine both of them and probably work in both fields. So, yeah.
Yeah. Yeah, that's really possible. I think there's somebody else. No? Yes.
Kimora, you did an amazing job. I mean, not only does this speak to your personal experience, but also to the relevance of CAR-T cell, that is transforming, the day-to-day therapy in cancer care. We are really proud of you, and I want to tell you that I look forward to an opportunity for you to continue doing this and to present. Don't keep this on the computer. This is something that is worth presenting outside of this symposium. So good job, and I look forward to more in the future.
Thank you so much once again for your patience, your presence, and all of your contributions towards moving medicine forward. Now, I'm going to be introducing our next speaker or our next presenter or the next moderator, or, she makes a lot of differences. Dr. Wang. So, where is my little thingy? Now, Dr. Shixia Wang, PhD, Professor, Department of Molecular and Cellular Biology, and Huffington Department of Education, Innovation and Technology, Director, Antibody-Based Proteomics Core at Baylor College of Medicine, with expertise in cancer research and advanced technology development. She has served as core director at genomics and proteomics facilities, developed advanced technologies in genetic engineering, genomics and proteomics, supported research programs, and co-authored over 80 publications, guys. That's not a joke. All right. Dr. Huang provides advanced technology education and training to students and faculty at academic institutions and secondary school communities, including establishing and leading biotechnology incubator for teachers and students, BRIGHT, with the support of the NIH R25 Science Education and Partnership Award. Dr. Wang is the Baylor College of Medicine lead of Collaborative Cancer Research Education Program, the CREP, within the BCM Texas Southern University P20 Collaborative Union for Cancer Research Education and Disparities CURED program. Ladies and gentlemen, please join me as we welcome this phenomenal Dr. Wang. A round of applause for her, please. Thank you.
Thank you so much, Chamsi. And it's inspirational when we listen to the talks for the first session. So now we're going to hear the amazing next session from the speakers. So first, Dandre, who has worked the first week in my core lab, and then I see him every day on the floor. So you are going to give a talk next about the 8 weeks. Dandre has the bachelor's degree in health science and an MPH in epidemiology. And then you're working to apply for the medical school to be an MD. That's amazing. So Dandre is passionate about promoting scientific discovery and giving back to the community through service and research. So Dandre? Did it work?
I wasn't going to talk. Do I need the microphone?
Yeah.
Okay. Okay. Good morning, you all. So I'm just going to stand right here. So as mentioned before, my name is Dontre Crump. I'm a post-bac student here at Texas Southern University, studying biomedical science. Over the past 8 weeks, I worked with Dr. Manoshki Anurag, whose primary goal is to focus on improving cancer diagnosis through clinical research, treatment, as well as survival using statistical analysis through medicine. Okay. And so my ultimate goal, what I want to talk to you all about, is how to use 15 specific genes to use as biomarkers to determine whether they will work for endocrine treatment that will help breast cancer patients. So estrogen receptor positive breast cancer is one of the most common subtypes of breast cancer, and it accounts for about 70% of all breast cancer cases. Some drugs that are typically used are aromatase inhibitors, such as anastrozole, which lowers the estrogen level, as well as fulvestrant, which is a selective estrogen receptor degrader, which blocks and breaks down the estrogen receptor itself. And so, while many of these drugs typically work well for many patients, statistics and studies show that around 1/3 of the tumor doesn't respond effectively. And that's like a key component to this issue that I was solving during my research studies. And the key sign to this is specifically when a Ki-67 index, which measures how fast tumor cells divide, is high, typically when 2 to 4 weeks of treatment. So that's basically telling you all that the tumor is still there and it's growing, even without relying on the estrogen, which makes the estrogen an independent resistant. And so to understand why all of this is happening, deals with a recent study called the alternate trial, which measures different type of profiling procedures, such as anastrozole, the medicine being tested by itself, the fulvestrant being tested by itself, as well as a combination of the anastrozole and the fulvestrant being done, while also doing other molecular profilings. Other studies did show that certain gene expression were linked to whether the tumor responded effectively or if it resisted the treatment. And so understanding and validating these signatures may improve patient outcomes through more personalized treatment, because the researchers, they used 2 different types of cell models. One was the MC47 and the T47D, which I'll be discussing with you all later in my results. And so with those 2 cell models they used, that allowed me to determine whether those same genes were expressed during my analysis. And so the big hypothesis, the question I'm trying to analyze, is whether a specific group of those 15 genes can tell the difference on whether breast cancer cells can be differentiated between sensitive or fulvestrant resistant, and whether it will help medical researchers and doctors determine if it will be helpful for cancer patients. And so for my methods, being that my background is in more statistics, I used RStudio, which is a computational data set, and it was downloaded to normalize the cells. So I grouped my cell lines based on whether they were fulvestrant resistant or if they were sensitive. Also, I validated those analyses on a 15 gene endocrine resistant signature discovered from ER positive, which is estrogen resistant positive breast cancer patients' tumors, and I performed different analyses such as t-testing and the Wilcoxon test, while also doing heat maps, box plots, and a PCA. So let's see my results. Oh, that's not work. So I'll just use my hand. So for my results, as mentioned before, I used 2 different types of cell line models. I used the MC47, which is one cell line model, as well as I used the T47D, which is the second type of cell line model. Notice how I differentiated my genes based on whether they were sensitive or if they were fulvestrant resistant. So if you see that the red and the blue, the red lets us know that it's upregulated, and the blue lets us know it's downregulated. So if you notice that it's positive and negative. So notice that you see both colors. It did show that it's differential expression within these genes using the t-test. And the reason why I use a t-test is because using a t-test is more accurate when you have a small sample size. And let's go now to the different cell line model, the T47D. As mentioned before, I grouped them based on whether they were sensitive in blue and red fulvestrant resistant. And with this cell line model, you see it's like a 50-50 chance, but you still distinct that it is differential expression patterns within the cell line model. And then for my results part, I did use a box plot within these 15 genes. This box plot normalized the gene expression for these 15 genes. So notice how you see 2 asterisks and you maybe see 3 and 1 asterisk. That's because I use something called a FDR, which is a false discovery rate, to normalize the p-values to get a more significant number. So with the 3 p-values, that lets us know that the p-value is less than 0.01. And the 2 asterisks let us know that the p-value is less than 0.01. And the 1 significant value lets us know that it's less than 0.05. And so notice how of these 15 genes, 13 of them tend to be significant. Specifically, gene GCH1 was not significant, and the PIF1 was found to be significantly upregulated. And in conclusion, based on my findings, it did support that potential biomarkers of those 15 genes will help with ER-positive breast cancer.
Any questions?
Question?
Yes.
Can you, okay. Okay, so my question is, when you were doing your t-testing, was it paired or unpaired?
It was paired.
Okay.
Yes.
Okay,
Paired.
cool. That was it.
How do you think that this will improve like cancer treatments in the future?
So, based on my research study, we did this analysis, try to warn patients beforehand. We're trying to detect it before they're already exposed to it. Because with these research articles, it happened after the trial, like after they were exposed to it. So my goal was to use these analyses to try to prevent it beforehand. And hopefully, based on these genes, maybe there could be another clinical trial coming up soon where they can probably prevent it.
Any other questions? I just want to make a comment. Amazing presentation and great research results. So it looks like you also used what you have been trained on the first week at the advanced technology course. I mean, you worked in the proteomics core and also the omics data analysis.
Yes.
That's amazing.
Yes.
Thank you, Dante.
Thank you.
Awesome. Dr. Wong, I have one comment for Dontre.
Yes.
Dontre, I just want to appreciate and acknowledge your commitment to this work. And not only does Dontre do his research work, he's also very committed to community engagement and outreach. 3 weeks ago, we had no-cost breast cancer screening for women during our outreach, and Dontre supported a lot of services that we provided. So he's not just doing, research with his statistics, he's also physically helping women gain access to care and for early detection of breast cancer. So good job to you, Dontre. Looking forward to the future.
Thank you.
Congratulations. Okay, next, Chinadu. Chinadu, it's a first-year pharmaceutical science PhD. Our VP already mentioned, has great future, and also worked at the antibody-based proteomics core in my lab. And your research interest includes oncology and formulation, and a career goal is to go through the industry route. Okay, so looking forward to your talk.
Thank you. So, my name is Chinadu Bube, and I am going into my second year in the PhD in pharmaceutical sciences. And during this program, I looked into the drug release of 5-aminosalicylic acid loaded nanoparticles. So, as an introduction, inflammatory bowel disease encompasses ulcerative colitis, colorectal cancer, and Crohn's disease, which are groups of chronic intestinal inflammatory diseases that are characterized pathologically by intestinal and inflammation and epithelial injury. Current treatments involve daily high doses of aminosalicylic acid, antibiotics, corticosteroids, and immunosuppressants with the aim of relieving the acute attacks and preventing relapse episodes.
So most of these drugs can be administered through oral, intramuscular, or intravenous routes with the purpose and the goal of reaching systemic levels. 5-aminosalicylic acid, or 5-ASA, is a widely used small molecule and anti-inflammatory drug, especially in the treatment of ulcerative colitis and other inflammatory bowel diseases, which patients typically who have ulcerative colitis long-term can lead to the getting diagnosed with colorectal cancer. So although its effectiveness can be limited by side effects such as nausea, vomiting, diarrhea, abdominal pain, hair loss, and skin irritation. So the importance of drug delivery. Drug delivery is a very fun and interesting topic that involves methods or technologies that transport drugs to specific sites in the body for release and absorption, with delivery systems designed to improve targeting efficacy and safety. And as we can see that on this picture, there are several different routes of drug delivery. The one route of drug delivery I'll be discussing is nanoparticles. So nanoparticles can enhance the stability and solubility of encapsulated drugs, facilitate membrane transport, and extend circulation time, thereby boosting safety and efficacy while minimizing the side effects of the target and off-target effects. Nanotechnology can address the limitations of traditional drug delivery, from broad challenges such as biodistribution to finer barriers like intracellular trafficking by enabling cell-specific targeting and precise molecular transport to organelles. And one example of nanoparticle is lipid nanoparticles. As I'm sure most of you guys know, the mRNA vaccine was utilized during COVID, so it's a very important topic. And then there's also polymeric nanoparticles, where the drug can be ingrained within the matrix or be within the inner core of the polymeric shell. So my goal was, for this program was to evaluate the drug release of 5-aminosalicylic acid, 5-ASA, using nanoparticles compared to the free or neat drug. So I first started by observing the PDI, or polydisparity index, of the drug in order to see the size distribution of the nanoparticles, which is useful for predicting its behavior in solution and biological systems. So the PDI was 0.659 with peak, or the highest peak of 1,247 plus or minus 126 nanometers for the standard deviation. This indicates that the majority of the particles were small to medium. However, looking at the Z average, or the intensity weighted mean of the nanoparticles in distribution, we can infer that the larger particles that were present in the solution might have skewed it upwards, indicating overall lower uniformity than we would have liked to see. But following this, I weighed about 3 milligrams of 5-ASA, as well as the 5-ASA loaded nanoparticle, and added 1.5 milliliters of the solvent to each tube. The 5-ASA loaded from there I added 500 microliters of each sample into 3 dialysis tubes, then placed them into beakers with 5 milliliters of PBS to determine the rate of when the drug will diffuse out of the tube and into the beaker via osmosis. I then collected 500 microliters from each beaker at different time points and replaced the volume taken with 500 microliters of PBS. Finally, I utilized the UPLC to analyze the overall drug release. When looking at the results, starting with the amount of drug released from 0 hours to 24 hours, we can see that 5-ASA loaded nanoparticles released at a much release much less drug over time compared to the free 5-ASA, which could also be seen by looking at the slope. Then looking at the percent release section, we can see that at 24 hours, only 0.2% of the drug-loaded nanoparticles were released compared to roughly 5.8% of the free 5-ASA, indicating significantly slower and sustained release. This could also suggest that 5-ASA loaded nanoparticles can be suitable can be a suitable candidate for targeted drug delivery to treat intestinal inflammatory diseases. So looking at the conclusion, 5-ASA loaded nanoparticles display controlled release, ensuring a constant plasma level of the drug, which will improve patient compliance and drug efficiency while minimizing the adverse effects of the drugs. Some limitations of the study is that if I could go back, I would look for the encapsulation efficiency of 5-ASA within the nanoparticle, along with, solving kind of HPLC errors faced within the lab. So this study can lay the groundwork for a future study delving into the use of curcumin-loaded nanoparticles, utilizing curcumin's anti-cancer effects in the treatment particles, utilizing curcumin's anti-cancer effects in the treatment leadership, and the esteemed members of my lab for being incredible teachers to me.
Thank you so much, Chinadu, for your amazing talk. So questions. We have time for 2 questions since we are running a little bit late. Yes.
So why was this important to you?
Well, I wanted to go into nanopart. Are you talking about the cancer aspect or the nanoparticle?
Either one.
Either one, okay. So the lab that I'm kind of interested in going into for my program at TSU has to do with the formulation of nanoparticles, as well as I also wanted to push myself. I haven't really done much in terms of pharmacokinetics, so I wanted to push myself to learn something new and to kind of implement that with something that I wanted to continue at TSU.
Did you enjoy it?
Definitely. It was very insightful. I did a lot more than I shared here, including creating some nanoparticles as well. So it was all very fun.
Okay, fantastic. So I think we have 2 questions already being asked by one person, right? that's okay, that's perfect. Let's move to another one. Sorry, we are running a little bit late. So for the next person, thank you so much for the amazing talk. And Deja worked in flow cytometry and cell sorting core. So graduated from Texas Southern University and pursuing a master's degree in environmental toxicology. I know you are all reading, so because we're running late, I'm going to just let you give the talk on the topic you have been working on. Thank you so much for the great work.
Good morning. Like she said, my name is Deja Douglas. I'm a graduate student at Texas Southern University, majoring in environmental toxicology, and I'm going into my 2nd year of my master's program. And over the summer, I had the opportunity to work in a dry lab at Baylor under Dr. Thrift and Dr. Shetty. And our research basically focused on esophageal cancer. And today I'll be going over, just giving you guys a quick overview of the updated trends in incidence and survival rates for esophageal cancer in the United States. So what is esophageal cancer? Esophageal cancer ranks among the top 10 cancers globally in both incidence and mortality. Incidence is 4 times higher in males with a median diagnosis age of 68. Esophageal adenocarcinoma is linked to obesity, GERD, better known as acid reflux, and Barrett's esophagus. It poses a significant public health concern worldwide. Prior seer-based research showed improved 5-year survival for early-stage diagnosis, and despite this, overall survival rates for esophageal cancer remains poor. My null hypothesis for this project was that there has been no change in incidence or survival for esophageal cancer over the past 20 years. The methods I used to collect my data since I was in the dry lab is SEER. And for the people that may not know what SEER is, SEER is a cancer statistics database website, and it stands for Surveillance, Epidemiology, and End Results. And it basically just shows the different many type of cancers and any data you want to collect on it regarding the incidence and the survival rates. The study population analysis focused on the adults diagnosed with esophageal cancer between 1975 and 2021. The incident rates was adjusted to the 2000 US standard population and reported as cases per million. And the survival analysts, 5-year relative survival rates were calculated using Kaplan-Meier method and age adjusted to the 2000 US standard population. And the reported detail incident and survival rates were presented both overall and stratified by the stage of the disease. And this first chart, I know it's kind of small, I'm sorry about that, but it just shows the overall incident rates of patients from 1975 to 2021, and it's grouped by ages, and this is the one that's showing the cases per million. This chart here is showing results for the incident and survival rates per population. So it's going by localized, regional, and distant, and also by still showing the ages between 1975 and 2021. And this one is the overall summary of the incident rates by population. So localized, regional, and distance. I wanted to show you guys from a clinical point of view of what esophageal cancer looks like. So from figure A to D, it shows a lesion growing over a short period of time because esophageal cancer is a fast-growing cancer. And so from A to D, D would be mostly like esophageal adenocarcinoma. That's the last stage of esophageal cancer. It forms at the ending of the tube, esophageal tube, and ends at the stomach. So at that point, mostly a patient would be in the last stages of esophageal cancer, and at that point, it's like really nothing the doctors or anyone could do. I just wanted to showcase the T&M staging. Most scientists and doctors, the system that most scientists and doctors use to identify esophageal cancer in patients. The T stands for the tumor, and it just shows the size and the growth into and past the esophageal wall. The nodes indicates if cancer has spread to the lymph nodes, and mitosis indicates whether cancer has spread it to the other organs. And this last image just shows the signs and symptoms of esophageal cancer. A couple of them are very common. So that's why esophageal cancer is a fast-growing cancer and also has a very low survival rate, because a lot of these symptoms and signs a lot of people have on an everyday basis, and they kind of ignore them. And also a lot of people are asymptomatic and don't show a lot of symptoms to different diseases. So that's why esophageal cancer has a very low survival rate. Conclusion, limited progress. Esophageal cancer, especially at the distant stage, has shown minimal improvement in incident and overall survival rates over the past 40 years. Comparison to other cancers, unlike more common cancers, esophageal cancer has lagged in survival rates and advancements. Need for actions, increased public health research and prevention efforts over urgently needed, particularly for regional and distant stage esophageal cancer. And at this time, I would like to thank the P20 CURED program for having me. my lab mentors at Baylor, Dr. Thrift and Dr. Shetty, for taking their time out their busy schedules to mentor me over the summer, and my family and friends for cheering me on during this progress. Questions?
Great presentation. Thank you so much. And the timing is perfect. All right, questions? Yes.
Okay, there we go. Okay. Did your lab mention anything that they were gonna do to improve this or do preventative care?
Well, for further research, they wanted to basically encourage patients to like speak up more when they're in the doctor's office, to let the doctor know that, hey, this may be going on with me. I don't know what signs and symptoms this correlates with the diseases. Basically just letting the patient know to talk, let people know what is wrong so that it can be caught early so you could prevent later on stages.
What was the most impactful, like what was most impactful about this project that you worked on?
That's a good question. I would say this was a learning experience overall for me because back here at TSU, I work in a wet lab. So to get the experience to work in a dry lab at Baylor, it was a learning experience. I really enjoyed it. Learning the different softwares, new softwares that I wasn't familiar with before I started. It was like a learning experience. I really enjoyed it.
All right, any more questions? All right, thank you so much for the amazing talk. All right, next we have Bianca, and who worked in this flow cytometer and cell sorting core as well in the first week, a junior at TSU, career interest in health and wellness, particularly developing programs that support healing, fun, and positive outcomes for underserved groups. I know you are all reading that out. Now you make your introduction and looking forward for an amazing talk.
Hello, everyone. My name is Bianca Matabuki. I am a rising senior majoring in biomedical science. My presentation is titled Neurocognitive Decline and Discrepancies in Parent and Patient Reported Emotional Functioning in Pediatric Brain Tumor Survivors. This study focuses on the cognitive and emotional and executive functioning outcomes in pediatric brain tumor survivors. Over time, survivors can experience a decline in brain functioning, impacting their daily life, school performance, and relationships. When we talk about pediatric brain tumors, they are the second most common cancer in children after leukemia. Symptoms can include headaches, seizures, nausea, vision, and/or speech challenges. More than 5,000 cases are diagnosed each year within the US. As you can see in the picture I presented down below, I showed the location of different types of brain tumors. In our project, we were able to gather two main hypotheses. The first one were being children who experience significant neurocognitive decline will report poor and emotional and executive functioning than children who experience stable neurocognitive functioning over time. And the second one was, we also expected parents would report more emotional and executive functioning for children who experience high significance of neurocognitive decline. The reason for testing does help families and schools understand brain tumors and the treatment it's impacted upon the child's thinking and learning and behavior. Patients in this study are able to undergo comprehensive evaluations such as examples like fine motor control, visual memory, and verbal memory. Within the project, we were able to study 134 pediatric brain tumor survivors who were younger than 18 and completed cancer treatment, such as surgery, chemotherapy, radiation, and rehabilitation services. Patients were able to think and problem solve. We were able to gather this information from the Wilshire Intelligence Scale. In this project, we were able to use tools for behavioral and emotional outcomes from parents and survivors. We gathered this information from forums like Connors 3, PedsQL, BASH 3, and Brief 2. As each patient also had a baseline and follow-up assessment that were 2.4 years apart. In the image below, we see the different types of testing assessments. For figure 4, it is the Berry VMI drawing test. Survivors are asked to copy geometric shapes that are useful for detecting difficulties in fine motor control. In figure 5, it is the WIS matrix reasoning test, as the children must choose the correct missing pieces of shapes, which are useful to detect processing speed and problem solving. In figure 6, it is the WIS block design test, where the child must be able to use the red and white blocks to copy a design given in a card that is shown. This detects the weaknesses in spatial awareness and coordination. On this slide, we were able to compare two groups of pediatric brain tumor survivors. Looking at the parent-reported group, we were able to see the significant challenges in inattention, learning problems, and executive functioning. The orange bars represent the IQ decline and are way higher in many areas that are approaching and or passing the red dashed line, which causes risk and clinical concern. Looking at the self-reported ratings on the right, we were able to see big notable differences in survivors who experience IQ decline, reporting high levels of hyperactivity, impulsivity, and aggression, and task completion, compared to those with no IQ change. As the IQ decline is linked to both cognitive and behavioral challenges, especially seen by parents, it highlights the needs for long-term monitoring and support. Many people wonder why there are differences within the self-reports and the parent reports. This is because children who recover from brain tumors have reduced self-awareness and changes in emotional and behavioral functioning, while on the other hand, parents are more likely to observe day-to-day behavior and recognize problems that the child might not see. In conclusion, neurocognitive decline in pediatric brain tumor survivors are linked to behavioral difficulties when reported by parents. It highlights the importance of multi-informant assessments to fully understand survivors and their challenges. Future research should explore parent-child reporting gaps, improve behavioral assessments, and targeted interventions for survivors and caregivers. I would like to thank the P20 CURED program, and as well as my lab mentors, Dr. Lisa Kahali, and my supervisor, Heather Stansel. Thank you.
Thank you, Bianca, for a great presentation. Questions? Yes.
Okay, hello. Okay. First of all, great presentation. How would you take what you learned from Baylor in this program and kind of apply it to what you plan to do in the future?
That's a good question. When I first came into the program, I was really interested in research. I just didn't know what field. So knowing that I was able to be in pediatric psychology, I think I want to spend more time trying to understand pediatric psychology, because it was just only 8 weeks, so I really don't have a definitive answer yet.
For other psychology students, since you said you want to spend more time in the pediatric psychology, Did you get a chance to observe the behavior assessments and interact with patients, or was it mostly data analysis?
So I was able to observe. I wasn't able to like do the assessments or like really interact just because it was like a thing with my mentor. She was real strict on that. So I was able to see how different assessments were provided with the survivors. We also were able to do testing assessments on leukemia patients as well, from the earliest ages, I believe 3, and then the latest age to be 18.
Fantastic. Thank you all so much. So we actually have 2 minutes extra. In that case, I rushed Chinadu earlier. So I apologize for that. If you have any questions for him, so you have a chance to ask him again.
Well, I do have a comment because I wanted to be conscious of time for all the 3 presenters. But all 3 of you did amazing, Chinedu. Like I told you on the office hour call, you need to work with Dr. J. Dr. J has an amazing nanoparticle discovery lab here funded by CPRIT. So it's going to be a seamless transition for you to keep doing what you're doing. So kudos and great job on that. Then Deja, your presentation was awesome. Where is she? Yeah, that was really great, esophageal cancer. And in your conclusion, you mentioned things about education, right? So that way we can ensure early detection and that even when people are diagnosed with the disease, they know how to manage it. TSU, we have an amazing community outreach infrastructure. So we are happy to connect with you. We have, Dr. Obo, Edith, a lot of great resource and support here for you to be able to keep doing what you are doing. So good job on that. And then Bianca, your presentation is really, really good. That is an area of unmet need. Just looking at that pediatric, population. So I'm hopeful that you have an opportunity to keep doing what you're doing. And to all of you, good job and kudos to you guys. Thank you.
Perfect timing, 12 sharp. So you have 5 minutes to stretch and come back at 12:05. Thank you all so much. All right, our first speaker is Al-Samabi Omakaro. I realized the introductions they gave is amazing. So I'll let you give your own introduction. Al-Samabi, amazing work during this summer, and you did the technology training at the mass spectrometry proteomics core. All right, thank you so much.
Hi everyone, my name is Osamagbe Omokaro. I'm a senior actually at TSU majoring in biology, and my project is it's about investigating biological and social determinants of racial disparities in prostate cancer incidence. Prostate cancer is one of the most diagnosed cancers amongst men in the United States. However, African American men are disproportionately affected, experiencing significantly higher incidence rates, more aggressive disease progression, and nearly double the mortality rate compared to white men. The direct cause remains unclear, but it is believed to involve a complex interaction of different components. These components include genetic predispositions, tumor biology, and social determinants of health such as healthcare access and socioeconomic status. This research aims to explore potential biological and environmental contributors. Preliminary metabolite profiling revealed distinct biochemical patterns between racial groups, suggesting potential biomarkers that could influence disease progression and detection. So our goal of this research is to identify key factors that can inform future interventions and reduce health disparities. Our central hypothesis is race-associated differences in metabolite expression contribute to the elevated burden of prostate cancer in African American men. We believe these differences play a biological role by influencing tumor behavior, progression, and even how the cancer responds to environmental or systemic factors such as inflammation or oxidative stress. In support of this, we also hypothesize that specific metabolites will differ significantly between African American and white prostate cancer patients. By identifying those key metabolomic differences, we can begin to understand how underlying biology may intersect with broader social determinants to impact disease outcomes. Ultimately, this approach can help uncover biomarkers that are not only predictive of aggressive disease, but also useful in guiding more personalized and equitable care for strategies for African American men who are disproportionately affected. So we have archived prostate tumor tissues from African American and white patients. They were analyzed. So we analyzed 422 men in total, and 69% of them were Black. High throughout metabolomics was performed to quantify metabolite expression levels across these samples. We have unpaired t-tests. We specifically did the Welch's t-test. That was conducted to identify metabolites with significant and insignificant differences in abundance between the two racial groups. Significantly altered metabolites were mapped to biological pathways to explore functional relevance. And then we did our pathway analysis, which considered clinical features such as tumor grade and stage to assess correlations with metabolite expression. And then we also did our data stratification as well. These two graphs on the screen show a comparison between African American and white prostate cancer patients in terms of Gleason scores and PSA levels, which are both key clinical markers. The Gleason scores on the left measures tumor aggressiveness, while PSA on the right is a blood marker used for detection. As shown, there's no statistically significant difference between the two groups for either marker. P-values are above 0.3 and 0.4, respectively. This shows that in the data set, race alone didn't drive differences in tumor grade or PSA levels at diagnosis. It highlights the importance of looking deeper beyond clinical efforts to understand disparities in outcomes. In our study, we focused on 3 biomarkers, adipocentin-resistant and osteoprogesterone, to better understand their roles in prostate cancer progression. First, we observed higher levels of adipocentin in metastatic prostate cancer compared to primary cases. This finding is particularly interesting because prior studies reported a reduction in adipocentin as tumors advanced, suggesting our cohort may present a distinct biological response. Next, for resistin, these levels were also significantly elevated in metastatic patients. Since resistin is an adipocyte hormone linked to inflammation, this supports the idea that systemic inflammation may increase with disease progression, potentially impacting prognosis and treatment response. Lastly, we examined osteoprogesterone, or OPG, a known regulator of bone metabolism. As expected, OPG levels were much higher in metastatic cases, which aligns with its roles in prostate cancer bone metastasis and further validates its potential as a biomarker. Together, these 3 findings help us better understand the biological landscape of prostate cancer, particularly in more advanced stages. In conclusion, our study identified significant differences in metabolite expression between African American men and white prostate cancer patients. These findings suggest that biological factors, specifically metabolomic profiles, may play a key role in the racial disparities seen in incidence and disease progression. This is important because some of these metabolites could serve as early biomarkers for aggressive disease, which are particularly in high-risk African American men. One strength of this work is its integration of both biological and social determinants of health, offering a more complete picture of this disparity. Another strength would be the size of our samples. We had about 300. Because our analysis included a large number of samples, the data is robust and statistically meaningful, which adds confidence to our findings. To take the next steps into the right direction, these metabolite markers across additional populations must be validated and explored in terms of how they might guide more personalized, equitable treatment strategies. And these are my acknowledgements. Thank you.
Thank you so much for an amazing presentation. Questions? This is a very important topic. All right, if there's no question, and then welcome to the next presenter. Thank you so much. All right, Sumaya Arawulo, next presenter. Sumaya worked at the protein production and characterization core for the first week, and then come to the research projects. You're going to have a great introduction of yourself and your lab as well.
My name is Sumaya Awolo. My major is biomedical science, and I'm a sophomore at Texas Southern University. And my lab mentors for this project were Carson Bush and Anthony Mustau. And the name of my project is Investigating Telomerase RNA Folding using DMS map. Telomerase is an enzyme that keeps the end of our chromosome telomerase from getting too short. It is important for cells' health and stability because short telomerase can cause cells to stop dividing. It needs human telomerase RNA as a template to add to DNA repeats. For telomerase to work, HTR needs to fold correctly and bind to its protein, the H-stretch, human telomerase reverse transcript. And as you can see over here, this is the overview of human telomerase RNA and the 3D structures. And this side is where the RNA binds, and this white is the enzyme's activities, and this purple is the protein that helps. And for the 3D structures, this is where the RNA binds. This is the protein that helps with it, and for the purple and for the green as well, the RNA folds. And for this to work, the RNA structure is very important. So we need to use a technique called dimethyl sulfate mutational profiling with sequencing. DMS map is a technique that allows us to study RNA structures in living cells. Before, they were only able to study the A and C base, limiting the structural resolution. But my lab, the Mostel lab, developed an advanced method using the N7 protection and a 4-base reverse transcription, enabling mutational detection at all 4-base nucleotide. This method increased sensitivity and accuracy in RNA structure mapping. Proper folding for HTR, particularly in the CR4 region and the pseudonuts, is crucial for binding to telomerase reverse transcripts. We think that with an optimal reverse transcription and amplification pipeline combined with multi-site DMS probing and N7 protection, we could preserve the chemical chains and see how HTR, the human telomerase RNA, folds in living cells. As you can see, these are the method. We probe HTR RNA in cell using dimethyl sulfate, the DMS, at a pH of 8.3 to induce the multi-site modification with ethanol as a control. Then we use the ultramarathon reverse transcript with N7 protection buffer to capture the DMS modification at all 4 bases. We perform PCR1 and PCR2 to amplify the cDNA, and we clean the dots using the magnetic bead purification. And we prepare our sample for Illumina sequencing, and we elevated the mutational signal to assess RNA folding. As you can see over here, this is the RNA structure, and this is the DMS. And over here is going through the mutational profiling, the map. Over here is the RNA and the cDNA aligning together, and over here are just the procedures, the pictures. And for the results, we got the DNA sequencing we ran was like actually low. The depth we got was actually low, but we actually received a mutational profile where we covered, showing the DMS modification and were encoded into cDNA. As you can see over here, this arc region is based on another arc. So these are the base pair. They have low reactivities, and this orange and red are the DMS that were altered by the RNA, so they have high reactivities, and this purple are the N7 protection that was bind to the RNA. So through fully structural analysis were limited by low read count, our experiments showed that the RNA structure probing and mutational capture were successful. This indicates that the 4-base N7 DMS map sequencing preparation pipeline work as intended, but further experiment needs to be done to verify this result and improve sequencing depth for more comprehensive structural mapping. And I want to thank the program leaders for giving me this opportunity, and my lab mentor, Anthony, Mustav, and Carson Bush, and my teams for being there for me. Thank you.
Thank you so much, and for a amazing presentation. Questions? This is a very important topic. So without questions, we'll go to the next speaker. Thank you. Okay, come on. So yeah, I'll let you make your own introduction and then about your research. So Kiora spent first week in the metabolics core facility for a week and then the research lab for 7 weeks. Looking forward to your presentation.
Good afternoon, everyone. As she said, my name is Kiara Davis. I am a senior biology major. So my presentation, the research that I did is on LEDM1 knockout and MCU knockout in Dr. Michael Brown's lab. For calcium enters mitochondria through the MCU, especially during high cellular activity. Inside calcium boosts ATP production by activating metabolic enzymes. LEDM1 helps regulate mitochondria calcium levels, possibly through calcium and hydrogen exchange, while MCU allows entry. LEDM1 maintains balance and prevents overload of deficiency. So LEDM1 is a mitochondrial protein that helps regulate calcium levels. When LEDM1 is deficient, calcium regulation inside the mitochondria is disrupted. This can cause reduced ATP production and is associated with conditions like muscle atrophy, seizures, and Wolff-Hisham syndrome. Muscle atrophy occurs when the muscles waste away due to lack of energy and stress inside the cells. Since calcium does play a key role in energy production, we wanted to explore whether blocking calcium through the MCU can channel and reduce the damage. So overall, the hypothesis proposes that muscle atrophy observed in LEDM1 deficient mice is due to mitochondrial calcium overload. Since MCU is the primary pathway for calcium entry into the mitochondria, deleting MCU may reduce this overload. As a result, MCU knockout could help preserve muscle structure and function in the absence of LEDM1. So for the methods, what we did is we took the quads of the mice with different gene knockouts. The muscles were sectioned and stained. We took the slides and we imaged them to measure individual muscle fiber size, and overall muscles were recorded for the comparison. So when it came to like the results and everything, right here you can see the images of the control and then of the LEDM1 knockout as well as the MCU knockout. So what I did was I took the numbers of the fiber size and everything, and then I graphed them to create a graph. Right here you can see they're not too far like apart from each other. So with this, it shows that knocking out MCU can possibly rescue it, but due to us only taking, this trial was about only like one trial with different quads, we would have to continue to do a few more other trials to see if it can completely rescue. So yes, as I said, MCU knockout may partially rescue the muscle atrophy seen in LEDM1 deficient mice. Further studies with larger sample sizes are needed to confirm whether MCU deletion can fully counteract the effects of LEDM1 loss on the muscle weight and fiber size. So due to us not really being able to say if this will work or not, I am luckily blessed to be able to get an opportunity to continue in my lab, to be able to do a few more trials to see if MCU knockout will be able to rescue. Now, when it comes to my acknowledgements, I want to definitely thank Dr. Michael Brown. He was amazing lab teacher, and everyone that was in my lab that I worked with. It's a huge list. As well as thanking the P20 for this opportunity. I am highly thankful, and it was a great experience.
Thank you. Amazing talk. Questions?
Since you want to be a trauma surgeon,
yes.
How did you like working, dissecting, and everything with the mice?
Okay, so this is gonna sound, for me, I feel like some people it's really weird. I actually highly enjoyed it. That was some of the favorite parts of my day. I'm gonna tell y'all, it's weird, I know. Favorite parts of the day coming in, I loved it, I enjoyed it. Cause it's not humans, but still gives you a little bit of practice. And like after like my first time learning it, it was just like a nothing for me. It was very fun. Yeah, I loved it.
I have a question as well about you studied the muscle of the mice.
Yes.
I know you described how you do that. Could you still describe it again, like the muscle? So you collect the muscle.
Yes.
And
So
then
yes. So we take the when we dissect and everything, we because we use the hearts as well because we're studying calcium uptake, but we take the quads as well as those mice and then we freeze them. And then we have a machine where we section it. It's kind of like a deli, like a little deli slicer. And we go in and we section them. It takes a few hours. It's a long process, guys. But you go and section it. Then we take them and we place those the things that we section on the slide so then we can stain them. And that process takes about 2 days. And then we use that. After that, we are able to image them and we can measure. We have a machine where we measure the size fibers.
that's fantastic. I remember I met Dr. Michael Brown in March when I was in a symposium like this. I just want to introduce myself to him, and he said, it's going to mentor a student.
Yes, yes.
Okay, great.
He's amazing, yes.
Thank you so much. Next, we're going to have Mia to present. So you will make your own introduction about yourself and the program. Mia was in cell sorting and flow cytometry the first week, and then spent another 7 weeks in the research lab. Let's hear what Mia is going to present.
Okay, hello everyone. My name is Maya. I am a rising first-year PharmD candidate at Texas Southern University, and my project was basically a drug development project, and we work with the drug ACAR as a therapeutic modulator of SPEG and calcium leak in cachexia. So cancer cachexia is actually a muscle wasting syndrome. It affects cancer patients, and it's basically a decline in muscle function due to their body is fighting off the disease, and also chemotherapy can have an impact as well. So it's characterized by a decrease in levels of SPEG, which is a striated muscle preferential express protein kinase, and an increase in calcium leak in the sarcoplasmic reticulum. SPEG is crucial for regulating calcium leak via the RY-R1 receptor, and a decline in SPEG activity is hypothesized to contribute directly to the calcium leak in the muscle. So ACAR is a drug, and it activates the AMPK protein kinase and is being investigated as a therapeutic agent. So the aim of my project was to determine if ACAR can restore SPEG activity and stop calcium leak. So my central hypothesis asserts that a decline in SPEG activity directly contributes to calcium leak and muscle dysfunction, and my aim was to investigate whether SPEG can be restored or enhanced by the drug ACAR. So for my methods, first I did have to dissect mice. So I dissected the legs of the mice and I extracted the soleus and EDO muscles from the leg. And then these muscles were isolated and treated with the drug ACAR for about 30 to 45 minutes. And then the muscle tissues were homogenized using zirconium beads, basically liquefying the muscle. The protein samples were loaded onto gels, and then Western blot analysis was used to determine whether the calcium leak was reduced or not. So these are some pictures. On the left, I have a picture of like the mice legs, and then in the middle there is a picture of, you can't see the muscles of course because they're very small, but they are in these vessels right here being treated with the drug. And then on the right side of the screen is the samples being homogenized for Western blot. So for my results, they're basically showing, this is my Western blot analysis. Our expected result was here in the middle section. We expected to see a decline in calcium leak, but due to, as you guys can see, the dark shading in that area, there was not a significant decline in calcium leak. There was actually a decline in where we weren't expecting in the S2902 antibody. So we kind of got opposite results what we were hoping for. We were hoping for calcium leak to be reduced in the RY-R1 receptor, and instead it was reduced in the 2902 receptor. So basically we just need to keep going. We need to keep optimizing the experiment. So we actually started a new trial of the experiment on Friday, and the results of that Western blot are being read today, probably right now as I'm talking to you guys. And these findings basically indicate the need for further optimization of experimental conditions. And yeah, I would like to thank everyone at TSU and Baylor College of Medicine, specifically my mentor, Dr. Susan Hamilton, my bench mentors, Chung So Lee and Ting Chang, and also my partner on this experiment, Sarah, who is a student at the University of Houston.
Thank you so much for an amazing talk. I saw questions already.
Great presentation. I have one question. What do you think were the factors that influenced the results that you were not expecting?
So I believe that we didn't put a high enough concentration of the drug in the first place. I also believe that treating the drugs for longer and also longer antibody treatment prior to Western blotting could also have an impact on that as well.
Yeah, sometimes the unexpected results could lead to new discovery. Maybe you'll find something totally new on that. Any other questions for Maya? All right, thank you so much, Maya. This is amazing. You all are incredible. So we have completed our third session. Oh, you have comments and questions?
Yes,
Veronica.
thank you. I wanted to wait till, the four presenters gave their presentation. Please, a round of applause for these amazing scholars. Your presentation really speaks of the depth of knowledge and your level of engagement in your individual labs. I am so wowed, with what you've presented. Osemagbe, prostate cancer is very near and dear to my heart. I'm sure you know that. When you guys came in, you probably picked up a packet that shows face-to-face, shoulder-to-shoulder. Let's talk about prostate cancer. So prostate cancer is that disease, like you mentioned, that is very prominent among Black community. So I look forward to an opportunity to work with you in that area, with outreach and whatever else you will be interested in. So good job and kudos to you on that. And for Sumaya, you really presented really, really well considering the extent of benchtop research that you did. I mean, that was just amazing. Good job to you. Good job to your mentors. And I look forward to an opportunity for you to continue to do what you're doing. You brought, benchtop research. You made it really easy to understand and to follow. That's a skill set in its own, right? That's not something that most people can do. So really kudos to you and good job. Kiara Davis, animal study. And you also talked about you have an opportunity to continue working with your mentor, right? I think definitely explore that opportunity because I felt like you took the first step and there's still multiple steps ahead of you. So please keep up that work and the fact that you enjoy the dissection and, going into lab and, really it speaks to your passion and your purpose. So please keep doing that and alignment with your goal of becoming a surgeon in the future. So really, really proud of you and congratulations. And then for Maya, where is Maya? Okay, yeah, you did amazing. So let me tell you this. In my PGY1, during my postgraduate year one experience as a resident, my project was on cachexia in cancer patients. And with that, I went to MD Anderson for 6 weeks to study total parenteral nutrition as a pharmacist. So there is a eating bubble, right? Where you have to not just address nutrition support for cancer patients by what they take by mouth, but there is a whole landscape of total parenteral nutrition, and clinical pharmacists plays an amazing role in doing that. So you being a PharmD student, you are going to encounter, TPN within your curriculum, but hopefully, if you keep up with cancer-related cachexia and things in that light, there are tons of opportunities for you to do that. Even now, as a clinical pharmacist, I still manage patients on total parenteral nutrition because of cancer-related, cachexia, malnutrition, and what have you. So kudos to you all, and thank you for this amazing presentation. Thank you.
Thank you, Veronica. So as Dr. Ojwa said, all your presentation, it's incredible. Not only on your research, not only this session, also all the morning sessions, the 3 sessions. I'm so impressed. Not only that you did your research so well, your time management. I was so impressed. So I went to so many conferences, but there are not many. We could get ahead of the time. So the reason Dr. Ojwa and I can talk over there because I know we all want to go to lunch, but we have extra times. So I want to congratulate you all. Also, I may seek for your mentorship for other students. Next year, I have several programs besides this one. I have medical student training, I have teachers training, I have high school students training. So actually on August 9th, Saturday from the other 2 Saturdays from now, and I have 135 high school students. They are going to make presentations like this. I mean, not all of them it's going to present the podium speech, but some will be posters, some will be presenters, some will be attendees. I want to see what's your trick. So come to tell me what's your trick to keep within the time limit. So because I really need to keep in the time limit. Yes. Oh, practice. Okay. So I'm going to email them to learn from you all. Says from today on, they need to practice. Yes. Okay, Brittany. I know you and I talked about you're going to relax. After this afternoon, you're not. I'm going to get your help for next 1 week and 2 days, 1 day. And then Brittany, maybe recruit some of you to train the high school students to present, because we really cannot delay on that all-day symposium. All right, I'll let you go to your lunch. Thank you so much and congratulations. Also, I want to thank everyone on Zoom, the mentors and other colleagues, and everyone over Zoom. Thank you so much for being with us. One is we have a special guest today, a mentor of the program and also a leader at Baylor, Dr. Sharon Prong, MD, PhD, who is a professor and also an assistant dean at the dual degree programs and pathways at the School of Medicine at Baylor, and a co-leader at the pediatric cancer program, and also director of the cancer genetics clinical and research programs at Texas Children's Hospital. So, and Dr. Sharon Prong is here, and she will give a few words. Thank you, Dr. Prong.
So, hi everyone. It was actually great. I haven't been on the TSU campus before, so Jasmine Baker, who's Jaden's lab mentor, and I were happy to come over. I'm just going to talk from the point of view of my assistant dean hat, which is that, Baylor has a variety of different training programs that people apply to at all different levels. So the medical school has applications for students straight out of college, but we also have a lot of students who apply to medical school after they've done a master's or even sometimes after they've done a PhD. So we certainly encourage people to consider that if you think being a physician is part of your career path. Baylor does, for the straight medical school application, Baylor does use the Texas system. So one thing that people aren't always aware of, I certainly wasn't aware of, is that the National Medical School application system is through AMCAS, but Texas actually has its own, because there are, I think, now 14 or 15 different medical school campuses. So we certainly encourage you to consider that. As part of the medical school, we do have what are called pathways, which are people that are interested in ethics or global health or care of the underserved. And those are ways in which you can do additional electives and get some additional training. The MD PhD program is a nationally funded effort through the National Institutes of Health. So for that program, we do actually use AMCAS. So it is a little bit tricky. You do have to decide sort of which path you think you're going if you're interested in the medical school. The graduate school obviously, again, takes students from all different backgrounds. And again, a number of the students applying to our graduate school have done masters in other institutions. But I'm delighted to work with Dr. Rouse. She and I are in the same division at Baylor, so I've known her actually since she was a fellow, and she obviously is incredibly enthusiastic, and I'm sure was delighted when this program was funded and with working with her colleagues here and at Baylor to put this program together. So do make sure you fill out any evaluation forms, because it's just to say program leaders really do use that information to make the program even better next year. And I was delighted to be a mentor this year in the program, and Jaden will be in the next group of presentations, but I look forward to hearing the whole sort of next group present, and happy to take any questions.
Thank you, Dr. Plum. So any questions for Dr. Plum? Yes, the incredible programs at Baylor. Thank you so much. Yeah, that leads to the next event during lunch. Brittany, that's the evaluation of the program. As Dr. Plum said, it will be incredibly helpful for us to improve the program to make it better for next year and the future years.
Thank you so much. And so I have the pleasure of introducing the program coordinator, at least on the TSU side, Ms. Brittany Garcia. And of course, she is the program coordinator for the Collaborative Union of Cancer Research and Educational Development Program, which is CURED for short, here at TSU. And in this role, she manages the daily operations of the program, supporting initiatives that advance health equity and engage diverse communities in addressing health disparities. So Brittany, of course, is passionate and empowering underserved populations through education, research, and community-focused solutions. She holds a Bachelor of Science in Health Science from Stephen F. Austin State University and a Master's of Public Health with a concentration in health promotion and community health sciences from Texas A&M. Her academic and professional work is dedicated to reducing health inequities and a focus on promoting better health outcomes for marginalized communities through evidence-based interventions and collaborative efforts. With a deep commitment to public health, Brittany strives to make a lasting impact on the well-being of individuals, like I'm sure we've all felt, and communities at large, working toward a more equitable and inclusive healthcare landscape. Without further ado, Ms. Garcia, thank you.
Thank you, Dr. Ogbo. So I will be moderating the last session. And so for the first person in this session is Ms. Raheel. She is a PharmD student here at Texas Southern University. Her interests include oncology, and so her career goal is to work in the oncology department as a pharmacist.
Good afternoon. My name is Raheel. I'm going into third year pharmacy school. Previously, I was at med school. I withdrew and came to pharmacy. So I was working with on socioeconomic status and bladder cancer with Dr. Patluri Agredi. This one, it was the research that they do mostly is on about why African Americans survivority rate is much less than European Americans. And they base it on the bladder cancer, which is an aggressive form of cancer. And that's where they mostly work on. And what they use, the techniques that they use to look into all these works are the mass spectrometry, nuclear magnetic resonance, chromatography, and all that. Okay, so the hypothesis is that, okay, the socioeconomic disparity or socioeconomic status of African Americans contributing to not being able to have healthcare access, and that affecting actually the cancer state, where it actually the DNA instead. So basically they study epigenetic.
Rahil, I'm sorry to interrupt you. If you don't mind, scoot over a little bit. Yourself, because you are behind the computer. The people online can't see you. And move your mic closer to your mouth, please. Thank you very much.
Can you see me now? Am I? Okay. So they work on the hypothesis is the hypothesis is that a methylation of the DNA. Normally, DNA, we need methylation in our DNA, but the methylation state of the DNA tumor is the one that is actually causing more aggressive state of the cancer. So that's the hypothesis they based it, and that is because of socioeconomic status where African Americans are not really with health insurance and accessibility to health cares. So on that, so not to go deeply into the scientific side of the tumor means causes instead of the tumor being a cancer state, it's becoming more aggressive. The tumor being suppressed to cause remission of the cancer state, it's becoming more aggressive. So normally after getting cancer, if the person is on remission state, that means the cancer, the tumor is still having that natural ability to activate the hydroxymethylcytosine, it's on letter B. But with the African American, what they are seeing is instead of hydroxymethylcytosine, it's becoming methylcytosine more. So that one, instead of increasing the cells that will combat the tumor, the coming cancer aggressiveness, it's actually changing the chemical state of initiating the oncogenes. And oncogenes are cancers that will actually, these are the graphs that I have. So A is showing the black diagram. It's the African Americans, where it shows a relative abundance of 5-methylcytosine. That's where the DNA, the tumor DNA, is highly methylated. And also at the bottom C, the red portion, that's the African Americans, where high methylation of most genes, including E, all the one in red, these are the highly methylated tumor cells. And these belong to the African Americans. That's the graph that is showing in here. And p-value using the t-test, that's what it's done. With the European Americans, they have more hydroxymethylcytosine, which helps them to exist a little more than the African Americans, which on A, it shows their survivability rate will be very, very low. And that's attributed mostly to not having better health care because of socioeconomic status, and also exposure to too much xenobiotics, smoking, all these work hazard environments like asbestos and all that. And having that 5-methylcytosine means the body is not eliminating it, it's retaining it. And that retention is the one causing the oncogene stimulation. So the conclusion is that hypermethylation in African Americans suppresses the gene that fights bladder cancer, and it actually aggravates the stimulation of oncogenes, further worsening the bladder cancer, and then reducing their survival rate. That's all I have. I really want to thank Dr. Negredi Patluri and Dr. Karthik. They were really, really awesome. Actually, Dr. Negredi, I think he wants me to continue working with him. And from TSU, Dr. Liang, Dr. O'Hare, and Dr. Keppers. They are actually the one who pushed me in it to go and then take this program. Thank you.
Thank you. Does anyone have any questions for Raheel?
A great presentation. What was the most impactful part of your, the study during the program?
So, okay, so I've been doing genetic research since 2009 with UH, TMC, before I joined med school. Always it interests me, genetics, but epigenetic that is a little bit more advanced because it normally doesn't change the DNA composition. It doesn't change the coding. It really intrigued me, like how does it give into a disease state without changing codes? Normally, it's when the code is either nonsense mutation, silent mutation, all those mutations that you get disease. But this one, nothing is changing, but the person has disease, and aggressive one. Mostly like the most cancers like bladder cancer, uterus cancer, breast cancer, these are aggressive ones. Even though you are on remission state, they have a chance of coming back. Recently, there was another study that came out. Okay, she has breast cancer, but she's cured. No, but then it comes back. But not only coming back, sometimes she has bone cancer after a while. Why? Epigenetics is the one that's studying this, and these people do work on that. So that's the most interesting part. That was her, yeah.
Thank you for the great presentation. Definitely epigenetics have a next layer of providing mechanisms in research. My question is about your own career goals. So what's your career goal? How do you think your research or continuing doing this research will impact your long-term goal?
So basically, it's about science. Science always interesting to me, but after pharmacy, I'm interested in cancer study, scientific work, oncology. So that's where I'm planning to go ahead. So I have started already shadowing some people. So that's the interest. Thank you.
Thank you, Raheel. Oh, it's okay.
Miss Brittany, I really want to thank her a lot. She has been taking a lot of questions from me. Her patience.
Okay, so the next presenter is Jaden. He is a graduate student here at Texas Southern University. His research interests include cardiovascular health and health equity, and his career goals are to work in clinical research and support underserved communities.
All right, good afternoon, everyone. My name is Jaden Murray, and I will be discussing today the clinical significance of SPINK1 in pancreatitis and pancreatic cancer risk. I've had the pleasure of working with Dr. Jasmine Baker and Dr. Sharon Plunge. She spoke earlier. So just to dive in, SPINK1 is a gene that regulates trypsin activity in the pancreas. It basically keeps the pancreas from digesting itself. Mutations in this gene, like what we see here in 34S, this is actually the full scientific name for it, and it's a mouthful. So in short, it's just, we say 3,4, or N34S. These genes are linked to hereditary pancreatitis, but at the same time, it may also increase your risk of pancreatic cancer. So here's the thing, the evidence is mixed. Some people get sick and develop symptoms, and some don't. So that's why sometimes it's referred to as a risk modifier gene, or in some cases, it could just be a direct cause, but that's what we're studying. That's the entire point. So if you were to ask me, Jaden, what's ClinGen? So how do we make sense of this? This is where it comes in. ClinGen is a national NIH initiative that evaluates gene-disease relationships. And this gives researchers like us a framework to determine if it's a gene that's actually causing it, or does it just show up by coincidence. So it ranges from definitive, strong, moderate, limited, no known disease relationships. Is it disputed, or is it just refuted? And as far as the hypothesis goes, let's see. So my hypothesis is that using ClinGen's framework in disease curation, it helps clarify SPINK1's role, especially the particular variant that I addressed earlier, N34S. We think it impairs the trypsin's inhibition, which leads to chronic inflammation in the pancreas over time. And that also increases your risk of developing pancreatic cancer itself. So we need more evidence to fully confirm that, which is another reason I decided to look into SPINK1. It's really sparked my interest. So as far as my methods go, my first approach, when I sat down and I looked at it, my question to myself was, does SPINK1 actually meet the ClinGen criteria for a valid gene-disease relationship? So I followed their framework and I developed the gene-disease relationship, collecting both genetic and experimental evidence. So they have things like case reports, functional studies, and co-segregation data. As far as the results go, here's what I found. SPINK1 mutations, especially in N34S, are commonly seen in patients with hereditary pancreatitis. But using ClinGen's curation system, the evidence linked between moderate to strong gene-disease relationships are still, full expert panel classification is still pending. As I mentioned earlier, it's still being studied. So it's still one of those questions. Does it actually relate to pancreatic cancer itself, or does it just contribute to pancreatitis? So although final expert classification is still pending, we also saw that SPINK1 mutates and it can co-occur with other genes such as PRSS1 or even the CTRC gene. And it can also increase, as we see here, pathogenicity and disease severity. So to wrap everything up, SPINK1 is a gene that shows us a moderate to strong link to pancreatitis, but the full classification is tough. With functional studies, especially for more variants, this highlights how potential or how powerful ClinGen's framework actually is when evaluating genes like SPINK1. So with that being said, they don't always have to be the same in every person. It's never going to be the same in each patient. Future research should clarify whether more diverse populations and deep expertise actually work. All right, and as far as my acknowledgements go, I would like to give thanks to everyone at Texas Southern University that contributed to this, the Baylor College of Medicine, and I'm incredibly indebted to Dr. Jasmine Baker and Dr. Sharon Plunn for all their patience and guidance these past 2 months, and that's it.
Thank you, Jaden. Does anyone have any questions for him?
So how would you like to use this for your career goal or expand upon this research for your interests?
I'm actually still working with Dr. We have more work to do since it's still being researched. I initially wanted to go, my focus was cardiovascular. I got my BLS certification last August, and I started studying for my ECG or EKG certification. So I started to learn the 12-strip, like the rhythm analysis, and then this opportunity landed in my lap. So I'm still really new to it. It's only been 2 months, so I can't really go too much into it. So give me about 2 more months, and maybe I'll be able to tell you.
Thank you, Jaden. That was impressive. Great talk. And I have a question about CleanGene. Looks like an amazing database. So a couple of questions. One, it's a publicly available database. The second question will be for the genes you have the variant of SPINK1. Looks like it's amazing. Could find all the association. So I have a gene. So how do I use that? Could you walk me through a little bit?
Are you asking me?
Or is this publicly available? Everybody could use it. We just
Yes, it's publicly available, but if you were to actually dive in and do the research, you have to register. Dr. Baker's actually helped me get registered. I'm going through the training as we speak. That way I can contribute to CleanGen in the future.
That's fantastic. So I come to you later on. So the second question is, how exactly do you do that? I know you already described it.
It's pretty broad, but if you take your time and explore CleanGen, you just type in what it is you're searching for, and you have other things such as like PubMed, PubTator. You type it in, and it's so many sources. I've even used Google Scholar, and a list of genes came up. I don't remember, but it's a long list. But SPINK1 definitely stood out since it's one of the ones still being researched. Pretty diverse. So,
Thank you. That's very helpful.
Yes, ma'am. Thank you.
Yeah, so ClinGen is nationally funded. All of the gene curation data, it's all on clinicalgenome.org. So you can search your favorite gene and see if there's already an expert panel. You can recommend it. The work that Jaden is doing and that Jasmine is coordinating, you do have to be a member of a ClinGen committee. They do take volunteers. We've had so much success with volunteers that right now we're not taking more volunteers, but we will be in the future. But the data is all publicly available.
Thank you so much.
Thank you.
Thank you, Jaden. So the next person to come up to present is Miss Jamie. She is a chemistry pre-med student here at TSU. Her research interests include cancer research, education and healthcare disparities, and the structure reactivity relationship of ruthenium, that's another hard word, complexes with chiral ligands. Her career goal is to become an anesthesiologist and eventually lead a fellowship or internship program.
Hello, hi, hope y'all are all doing well. My name is Jamie, and I'm a senior at Texas Southern University, majoring in chemistry on a pre-med track. Now, how do I need this wrong? Okay. Today I'll be presenting investigating the tumor suppressor role of FAT1 in ER-positive breast cancer. And I had the opportunity to work with Tagari and June in the molecular and human genetics lab at Baylor. Okay. So FAT1 is a tumor suppressor gene involved in the hippo signaling pathway. Most studies only examine partial regions of the gene because of its long amino acid chain. Loss or mutation of FAT1 has been linked to abnormal cell growth and cancer progression. ER-positive breast cancer is commonly treated with CDK4 and 6 inhibitors, but resistance remains a challenge still. Understanding FAT1's role may reveal mechanisms behind the treatment resistance, and this project investigates the functional impact of a point mutation in FAT1 exon 10. We use site-directed mutagenesis, transfection, Western blotting, and SRBSA to analyze FAT1's expression and effect on proliferation. The hypothesis of this project is the loss of the FAT1 tumor suppressor gene contributes to resistance to CDK4 and 6 inhibitors in ER-positive breast cancer by dysregulating the hippo signaling pathway and upregulating the CDK6. The methods that were used, we started off with cell culture and we just maintained the HEK 293 cell line under standard condition. And then we did site-directed mutagenesis, which is where we introduced a point mutation from cytosine to adenine in FAT1 exon 10, which is a common site observed in cancer data sets. After we went in with plasmid preparation, which is where we took the mutant and FAT1, the mutant and wild FAT1 plasmids and amplified and purified them using a plasmid mini prep kit, and we verified that by sequencing. And then we delivered the wild type and mutant FAT1 plasmids into the cell line, and we checked the transfection using Western blotting, and we collected the protein lysates post-transfection and analyzed the FAT1 protein expression using specific antibodies. Then we performed SRBSA to assess cell proliferation over 5 days, which the absorbance was measured at 510 nanometers to qualify total cellular protein. And based on the results, you can see from the cloning that it was successful, and we introduced this specific point mutation to mimic a common singular nucleotide polymorphism that's found in African Americans and Hispanics. Based on the results from the Western blotting, we can also see that the mutation was well expressed and that it increased in protein expression as well compared to the other vectors. And this is the results from the SRB. And we can suggest that FAT1 needs exon 10 for important functions, because based off of the proliferation, it went without exon 10, it's lower, versus compared with it, it's more higher. We never got to see well, I didn't get to see the results from the SRB with the mutation, but this is the results without it. And yeah. And we can conclude that we successfully introduced cytosine to adenine point mutation in FAT1 exon 10 using site-directed mutagenesis. And Western blotting revealed the increased FAT1 protein expression in the mutant compared to the wild type. Due to the gene's large size and long amino acid chain, it can affect protein turnover and stability. The results support the idea that changes in FAT1 expression can influence pathways like HIPAA. Future studies will also show how this mutation impacts CDK6 levels and therapy resistance mechanisms. And I just wanted to thank you guys for listening. And yeah, these are all my acknowledgements.
Thank you, Julie. Does anyone have any questions?
Very nice talk. So you said that's a polymorphism that's more common in certain populations. Does that C to A make a missense change or protein change, or what is it thought to do to the gene?
I'm not quite sure what it does to the
the gene specifically, because we never really got to see the to view it from more of a functional aspect.
Right.
But I just know that we introduced the point mutation because we were trying to change the genetic sequencing to mimic more African Americans
Yeah.
and Hispanics.
No, the experiment makes perfect sense. You may just want to, a base change like that can cause a protein change. It can cause the protein to stop there. There's a variety of effects. That's why I was just wondering what it's predicted to do. But
Any other questions? Well, thank you, Jamie. Okay, we're finally here. She's waited so patiently. The next person is Miss Kiera. She is a graduate student here at Texas Southern University. She has majored in nutrition and dietetic sciences. Her career interests include innovation research that improves the health of underserved communities and increases access to healthcare, nutrition, and education.
Hello, I'm gonna use the remote. All right, today. So my name is Kiera Baldridge. As she said, I did study nutrition. I don't know how I ended up in P20 CURED doing cancer research, but I'm very glad I did. I had the privilege of working with Dr. Sharma, a radiation oncologist, to understand why the uterus or how the uterus moves and what factors contribute to movement during radiation therapy. So there's common modalities for cancer treatment. You all probably may know about surgery, you probably may know about chemotherapy, but radiation is one of the ones that's not as commonly known. So I'm gonna explain to you what radiation does. So radiation uses electromagnetic rays to break the water molecule in a cell. Once it breaks the water molecule in a cell, then this causes free radicals to form. And you know free radicals lead to cell damage. Once the cells are damaged, they eventually die. That is what radiation does. It's a multi-day, multi-week treatment. So the patient will come every single day and they'll use the radiation to eventually lead to a DNA break of the cancer cells, and then they'll die off. So the goal for an optimal radiation treatment is for us to only kill the cancer cells and not to damage the DNA of the surrounding normal structures. So we only want to damage the cancer DNA, not the surrounding organs. So radiation therapy, I have to put the remote down just because it's better if I show you this way. The treatment started in a 2D plane, very flat. So it was more like this. That's the way the dose was. So you can imagine how we're not only treating the tumor, but we're treating surrounding structures. Then we moved to 3D. 3D became slightly more conformal for the dose. Now we're at the point where we have IMRT, which is extremely conformal, very precise. We can actually conform the dose to the shape of the tumor because it's very irregular. That's why my hands is like this, not like this. So now that we can conform to the shape of the tumor, we have to account for tumor movement because you're so precise. What if you're so close that the tumor moves and the next time that you try to treat, then it falls outside of your target area? So there's this thing that the physicians use called a fixed margin, which is just a little bit of extra space around the shape of the tumor to make sure that they don't miss any part of the tumor. But in our case, what if the tumor still moves in a way internally that we cannot predict and it falls outside of this margin still? So that's what I'm going to talk about. Okay, so the patient is going to have a consult. The most important things here is that radiation treatment is a multi-step process. We can't just bring you into the hospital and start, spitting rays onto your treatment area. We take you into a CT simulation where we take an entire CT scan of your treatment area. In our case, for gynecological cancers, is going to be your pelvis. So that's where the cancer is, the uterus. So we're going to take a CT scan of that, and we use that simulation scan, which is probably done on your first appointment with the radiation oncologist. We use that to plan your treatment. Once that treatment is planned, we use that same plan for the daily delivery of the treatment. So this could pose some issues, because what if when the patient comes back one day, their uterus is not in the same spot? And we already planned the treatment area. So we're trying to figure out why this happens. Okay. Our challenge, like I said, is internal organ motion. Now, you know that the bladder fills and empties. You know the rectum fills and empties. But what about the uterus for gynecological cancer? So in order to account for uterine movement, that's very important because this is gynecological cancer, as I've said the third time right now. We do a full bladder scan to see where the uterus is when the bladder is completely full, and then an empty bladder scan to see where the uterus is when the bladder is empty. So there's expectations for how the uterus should move, but every patient is not the same. Every patient doesn't have the same uterus. So right now we're using fixed margins and generalized guidelines in order to treat these patients. But what if some people don't move as much or as little as others? So that poses the risk of us overexposing some people whose uterus may not move that much, or underexposing, missing the target for some people whose uterus moves way more than we expected it to move over the course of treatment, since it is every single day. So the main important part on this slide is that what I was doing, the goal was to begin a study to understand what patient factors contribute to more uterine movement. So demographic, anatomical, how big the uterus is, how small the uterus is, if they have more subcutaneous fat, if they have less, if they're younger, if they're older, what contributes to this happening? That way we can make a personalized plan. So medicine is evolving very well. I know in my case for nutrition, making personalized plans instead of just using general guidelines for every single patient. So the way that we did this was I learned how to contour. So I am a nutrition student, so I didn't know anything about this until 4 weeks ago. So please bear with me if you are also a radiation oncologist and you notice my contouring is not perfect. It is good enough, and I think I did a good job for 4 weeks. So as you can see right here, I just wanted to show you what we use. This is what I was using for the entirety of the 6 weeks that I was there. This is the axial view. You have the sagittal view, which is important because I'm going to come back to that, and the coronal view. So this right here is the rectum. On the axial view and the sagittal view, it's normally going to be the most posterior structure. And then we have the bladder right here and the uterus, okay? This is just, I just wanted you to see that on the contouring in velocity, there's around 100 to 150 slices. So we don't just pull up one image, circle it, move on. You have to go through every single slice and contour where that structure is on every single slice. And the patient, I'm gonna explain this more, the cone beam CT is taken every time a patient gets treatment. So it's not as clear as a normal CT scan is. So the resolution is a little bit lower, and you do this every day just to see what has changed since they got the treatment the day before. So the results. Now, this was a very small study because, like I said, I just learned how to contour. So it was not easy. The 100 to 150 slices did not allow me to do 50 patients, which would be our goal, is to do 30 to 50 patients in order to really understand what the trend is. But in our case, I want you to pay attention to this purple line and pay attention to this green line. That's the bladder. So the bladder does not just full and empty. Sometimes it's medium. You know, sometimes it's very empty. Sometimes it's very full. You know, the bladder can become very, very much larger than you all probably may know, and I'll show you the way that that looks on a CT scan. But these variations from day to day for patients were very high. And that's important because you always want to improve medicine. You never want a risk of missing your target. You want the patient to come in and leave better than they came in. So let me show you. an actual image. Okay, so this is the sagittal plane point of view, like I mentioned before. Now the uterus is going to be sitting in the middle of each of these, right? So you can see the uterus in pink. I'm sorry I didn't do the same color. My mentor did say that when I turned in the project, that I did not do the same color for the structures on this, but the uterus is in pink, blue, and purple, okay? So this patient has a bit of a larger uterus because you can see in the middle of patient number 2, this is the uterus. Look how small that is, okay? So when her bladder's full, her uterus is sitting right here. So you could, this is the fundus of the uterus. So we to look at the location, we compare like the fundus to this sacrum point, okay? So you see how close kind of it is to this sacrum point. When her bladder emptied, you would expect for her bladder to, just fall over because it no longer has this structure here. Her bladder turned from anteverted to retroverted, okay? So that's not expected. And everybody's bladder doesn't do that. I'm gonna show you a patient who has the same size uterus on the next slide, and hers didn't do the same. So in this patient, no matter what volume her bladder was at, her uterus barely moved. So imagine if we use that fixed margin on this patient, we could miss her, okay? If we use that fixed margin on this patient, we could over-radiate the surrounding structures, and we don't wanna do that. We want ethically, because physicians do sign an ethical, contract, we wanna do the best possible treatment for our patient, okay? So this is the patient I said had the similar size uterus. We're still in the sagittal point of view. You can still see the sacrum and the fundus of the uterus. Bladder's about the same size as here and here. Here's her uterus. When her bladder emptied, her uterus fell on top. We don't know why, but her uterus did. So even though this was a very small study, we did make observations that every patient's uterus is not gonna move the same. When the bladder is empty and full, you cannot just, we're not able to completely and precisely use this margin to treat someone's uterus who moves in a way we didn't expect because of the possibility of geographical miss. So in the future, like I said, we do wanna use what we already know, that the bladder varies daily, okay? And that the rectum barely varies. And that there are possible factors such as parity and age that can contribute to the uterus moving more or less. Parity is the amount of children that you have. So there's ligaments, okay? You have your uterus, I'm the uterus, and then these are the ligaments, right? The more children that I have, I'm growing and I'm stretching, okay? These ligaments are like, okay, they're stretching as well with me. And then, it shrinks back, it goes back to normal, but then you have another child. And then you have another child. So the more times you do this, the more possibility that those ligaments can not be as tight as they were before, and then your uterus can do more and move more freely. It's not gonna move the same as somebody who's young and never had any children. It might stay in the same place. And like I said, we are making a personalized, predictive model so that when we get certain types of patients, we will already know, I don't need this much of a fixed margin in order to treat her. I can save this much of her surrounding structures wherever the tumor is and just treat the DNA cancer cells like I said in the beginning. Okay, so that's very important. Another thing that I did forget to mention before I move on is I want you guys to understand that the IMRT method that I said from the 3D method, we can plan how the angle of the beams are. So it's a lot of physics and dosimetry and everything that's included in radiation treatment. So they can decide exactly where the angle goes and how much goes where now. So we don't have to do the same concentration of radiation to the entire area of the tumor. Maybe this part's closer to normal structures than the middle part of the tumor. So we're gonna radiate this part less than we radiate this part. So it's very advanced. If you're ever interested in becoming a radiation oncologist, or if you ever have a loved one that has to go under radiation treatment, you can count on the advancements and the precision of this treatment. This is just a way to improve it because, like I said, it's never a bad thing for us to be more precise and better at our treatments. That's the goal of a physician. I do want to thank Dr. Sharma, who I hope is listening to me, and I hope is proud. Because she did a really good job at teaching me, really great teacher. I'm very happy that I got to work under her. I don't know many nutrition students who were able to get experience in cancer research, especially right under a radiation oncologist. The whole team at Baylor St. Luke's was amazing. I also want to thank Dr. Shea. I hope she is listening because I cannot see her because she's the reason I'm here. She gave me this opportunity, even though I am a nutrition student, I'm gonna stress that because this is just very new to me, and I'm so grateful for all that I was able to learn in 6 weeks. Like this is clinical data. We put this together ourselves. There's nobody else's images in this PowerPoint. We did all this work together, and she was a very great mentor. I also, like all people do on camera, I want to thank my mother because she's right there, and she drove 17 hours to be here. So thank you, Mom, for driving 17 hours to be here. So thank you, Brittany, and everyone else who put P20 together. You did a great job, And I just hope that one day, like Dr. Ajwale said, that we pave the way forward. And I hope that Dr. Sharma is proud because I hope that the next student can have a good time and not be cut off because of me. So thank you very much.
Thank you so much. Does anyone have any questions for her? Oh,
okay. Come on, man. This is not right.
Well, first I want to say I loved your presentation. Very engaging. It was amazing and great information to know. I do want to say, as being a woman, and working with this, how do you feel like? Did it give any more importance to you, and give you more passion with working with this?
I would say one of the things that I really appreciated was seeing the patients in a vulnerable state. So not only did Dr. Sharma have me in a dry lab staring at a computer all day, she took me to see patients. And some patients have breast cancer. Some patients have a small tumor that doesn't really harm them in any way. But it was very nice to see women. There was this one elderly lady who was, I know it's not Tulum. I think she was going to Napa, and she was, I don't know how old she was, I can't say, but she was there so that she can get radiation treatment. But instead of being sad and depressed, I know mental health is important, but it was nice to see that she was like, I got a trip to Napa after this, so when can we be done? When can you schedule me so I can make my trip? I think sometimes when you get a diagnosis, especially as a woman, or maybe as someone who's single, or you don't have any family, it can be very challenging, and then your mental health can kick if you don't have a community. So it was really nice to see she has a community. She was still living life. It didn't matter that she was getting radiation treatment. She's like, what after this? So I think that's one thing that I learned from the patients, taking it away, along with the patients who maybe didn't have something as serious as breast cancer or gynecological cancer. So that's what I learned.
Okay, I have a question for you.
Yes, ma'am.
I know you said you're nutrition, and this is a little bit. So my question is the movement of uterus. I know it's called brachytherapy. Does it depend on the high dose, low dose, or pulse rate therapy, or does it only depend on the one you?
So what you're mentioning, I didn't say this in here. Brachytherapy, so the whole treatment that I just described to you is outside the body. It's external. Brachytherapy is internal. Okay. So I don't know, because I didn't study that part, how the uterus moves when they do an internal radiation treatment, but it can still be predicted based off of what we've seen thus far that it depends on who the patient is and their medical history. Yes, Amira.
Thank you so much. Those patients that you showed the radiographic pictures of them, both has the same count of the childs. I mean, they were.
That's a good question. So I actually didn't have. That's a good question for Dr. Sharma. I'm sorry, because I didn't have access to that part of the patient's files. Okay. So by the time we finished
all the contouring and the measuring and the inputting that I didn't get a chance to see how many children they had. But I can ask for you. You want to know later?
Thank you. Yeah, I will catch to you later.
Yeah, I can ask.
Yeah, this is incredible. I have a comment and a question for you. The way you talk about the project looks like you have been waiting for this project all your life. My question was, is this because of the project you love so much, or you are just passionate on whatever you do? You're a nutrition student, you said.
I think it's because of God. I love learning. That's just on my heart, and He made my heart. And if I continue, I'll cry. So I'm gonna stop there. I just really love learning, and that's a blessing in itself.
Congratulations to you and to Mama as well.
That was an incredible presentation. Please, another round of applause for her.
Thank you.
Yeah, you could see the passion, the drive, the commitment to everything that she said, and that is amazing. We would love to see young people like you and the rest of the other speakers show a lot of passion towards what they're doing. So with regards to the IMRT, the intensity modulated radiation therapy, how much is being done to prevent toxicity as far as this type of radiation is concerned? I mean,
Yes.
Thank you.
So, as far as I know, like I said, they do look every single day of treatment to see what's changed, to make sure what they calculated in the beginning still looks the same, their treatment plan. And in addition to that, I did lose my train of thought there. Give me 1 second, because it'll come back. What was your question? You said. Yes, there we go. Okay. So they do the every single day cone beam CT scans to make sure everything is the same. And IMRT itself is a evolutionized form of the 3D so that they can be very conformal to that shape of the target. And then at the same time, there's not as much of a risk as radiation as people think. You know, if you get, Dr. Sharma used to always say, if you get radiation in your uterus, it's not gonna affect your brain. You know, it's not gonna cause hair loss in your head area. If you get radiation of a tumor here, you know, it's not going to have any effect. It doesn't spread, you know, and then you're not gonna be electric. You can't electrify anybody. So the treatment itself stops and ends on the table. So that's the best way that I can answer that. Is they've come a long way to be as precise as possible using 3D imaging, and then the radiation doesn't spread as people may think, because that's a question a lot of patients have. Yeah. Thank you for repeating your question. Yeah. Oh, thank you. That's it. Thank you.
Thank you.
Thank you.
So next is, I wanted to, oh, no, never mind, Dr. is talking.
Not a problem at all, Brittany. Please, team, help me to applaud the efforts of these last 4 presenters. They pulled the energy through. That is amazing, amazing work. I'm just going to give, a couple of comments for each of the presenters. Rahel, I think, the work you did on bladder cancer. So that project is actually one of the pilot projects. So Dr. Plum, that's one of the pilot projects of the P20 CURED, led by the team there, as well as team members here at TSU. So saying that there is naturally an opportunity for continued engagement if you so desire. So you did great, and we will love to be able to engage more with you in that regard. Jaden, that was such a great presentation. Like, how do you switch from cardiology into oncology, right? But surprise, there is an aspect called cardio-oncology. Yes, there is. I work with them all the time. I have publications with them with oral chemo. So oral chemotherapy causes a lot of cardiac toxicity. So at Houston Methodist Cancer Center, we have a special clinic called cardio-oncology. So our Exactly, it's because a lot of chemotherapy causes cardiotoxicity. So all those EKG strips is going to make sense. So there is a way, right? We can definitely figure it out. So stay engaged, do more of it. If that's a path you want to, carve for your future, we can definitely talk more about it. But kudos and congratulations. Jamie Armstrong, you did amazing. Breast cancer CKD inhibitors, that was really great. That was also one of the pilot projects under the P20 CURED. So Dr. Rodney Ontal is also a clinical pharmacist. He's the counterpart on TSU side. So again, another way for a natural progression into future engagements. So, keep up the work, keep up. Breast cancer is another, major disease that unfortunately impacts a lot of people in our community. So it's very, very critically relevant. And I look forward to working with you in the future. Kiara, oh my goodness, you need to package your energy and just, put it, sell it or something. That was such amazing passion and purpose. I couldn't have said it better. That was really, really good. I mean, even at every of the office hours that I attended, she was always there. She was always engaged. She had something exciting to tell us about the radiation therapy. I mean, your background from nutrition into radiation and what you've done today is just a display of passion and purpose. So keep up the work. And one thing that I also want to tell you is during my PGY2 rotation, I did radiation therapy as a rotation because I was just very curious, like what is happening in radiation? So there is definitely a link between nutrition because as people lose weight in cancer care, you have to re-image them. You have to do that contouring again. What you showed obviously was bladder related, bladder emptying and things like that. But in this case, people are losing weight progressively and you have to take them back and re-image and make sure that you are targeting the right spot on radiation therapy. So nutrition, radiation therapy, again, there is a relationship and there is a link. So kudos to you. I look forward to the future with you and with the great things that God has ahead of you. And before I hand it back to Brittany, I just want to say a big kudos to all 16 scholars. You all please give it up for yourselves. Give it up for yourselves, guys. I mean, you didn't make it feel like it's been, 4 or 5 hours of us being in this room. Each of you, you've displayed to us that you owned your experiences. These are presentations that you could take anywhere with you. It's not just a word on your CV anymore. It is an experience that you can speak to. So we are very, very proud of you. Not only did you guys engage in presenting, you also engaged with each other. Look at the questions that we're asking each other. I'm like, wow, there's just a lot of curiosity in the room, not just for yourselves, but also for your colleagues. So we are very, very proud of you. Good job and kudos. Brittany, I turn it back to you. Thank you.
Thank you, everyone, again for all your presentations. And before we continue, I just want to say thank you to all of you for all your hard work. It has been an interesting 8 weeks, highs and lows, but I really appreciate all of you. And I know Dr. Zhao Lin couldn't be here today. She's the Program Management Associate over at Baylor, but I know she is just as proud as you guys, and so we thank you guys a lot. Yes, so to go over the QR code that is in your booklets and on the screen, we have the abstracts, all your abstracts. So if anyone wants to take a look at that, you may, and then also the post survey for the summer research experience for the P20 scholars specifically. We really value your feedback, and so if y'all could take some time to complete that, and with time.
Thank you, Dr. Plon. Could not have been better said, please. We really need a survey to continue to get the funds to provide services like this for future students. Thank you, guys. Yeah, please, right, Brittany? We allow a few minutes for them to do it now?
Yes, that's fine. Okay.
Yeah, maybe about 5-10 minutes, please. Yeah.
Yes.
Please, thank you. And the QR code is on your booklet if you need to scan it from there. Thank you.
All right, everyone. So the next, before we wrap up for today's symposium, we wanted to give y'all the opportunity to meet your potential TSU career development tours. A couple of them couldn't make it today, but we have, I believe, half of them here. And so we were just going to have them give a little introduction. So I will start off with Grace, if she wants to come up and introduce herself. Know who I was going to call first, so they've all been waiting very patiently.
Hello, my name is Grace Salonyomi. I'm a toxicologist and a postdoctoral fellow at MH-REACH, which is the Maternal and Child Health Center here at Texas Southern University, and is also under College of Pharmacy and Health Sciences. Currently, I'm working on effects of environmental chemical exposures on maternal and child health, particularly prenatal exposures on the effect and the effect on maternal and child health. And I also have will potentially have a community engagement angle, which is increasing awareness and education on the effect of environmental chemicals like PFAS, heavy metals on maternal and child health, and considering the impact that nutrition and diet plays in safeguarding or protecting against those effects. That's basically it. Thank you.
Thank you, Grace. The next mentor I want to bring up is Miss Cecilia Torres.
Howdy, everybody. My name is Cecilia Torres, and I'm an epidemiologist here at Texas Southern University in the College of Pharmacy and Health Sciences. I also serve as the program coordinator for our maternal and child health program here, MH-REACH. And just because Dr. Ajewale is here, I also serve as her graphic designer for all her programs. So I mostly focus on maternal and child health research here at the university, but I also dabbled a little bit in environmental as well as GIS and geographical spacing. And I also serve as a SAS programming specialist here on campus. So I teach a lot of the SAS programming courses and help out with mentoring in the College of Pharmacy as well. So I do a lot of high school, undergrad, and grad student mentoring programs to help do career development for that as well. And I'm just so excited that this program exists. For like my own personal life, my mother, she just got into remission from her third cancer. So I'm just so glad that there are students like you that are going into the cancer research field trying to make a difference. So thank you.
Thank you so much, Cecilia. The next mentor that I want to call up is Mark.
Good afternoon, y'all. First, I just want to say you guys did amazing. I was very, very impressed with each one of your presentations. My name is Mark Ibarra. I have been in the clinical research field for around 4 years now. Most of my experience comes from ophthalmology, but I've also worked with different hepatology studies. Currently at Texas Southern University, we are implementing a clinical research site. I would like to say that we've successfully implemented the clinical research site already. Right now, we're currently working on a clinical research registry. That's basically a database to help us facilitate recruitment for future clinical research studies. So yeah, I'm excited to be one of your mentors, although I feel like you guys should be my mentor and I should be the mentee, but yeah, I'm excited. Thank you.
Thank you. So you've already met the last two people, but I'm still going to have them come up and speak because they have a lot of experience. The next person is going to be Miss Edith.
Thank you so much, Brittany. Thank you so much. It's always a pleasure to be among young people who are doing phenomenally well. I am so honored to be here. Thank you all for coming around. Thank you for the great presentations. A round of applause for all of you, please. Put your hands together for yourselves. And thanks to all the family members who came to support. Thank you, Mom. Thank you, family member. Mom, okay. Oh, wonderful. Thank you so much for coming. You know, I always tell people sometimes you don't realize how much your parents put into some of the things that you do. I have a lot to be thankful for because my mom helps to make sure that I'm still sane while going to school and working. I'm not coming to work with my baby on my back, So yeah, so my name is Edith Declan. It is a pleasure to be here. Thank you all for the opportunity. Thank you, Brittany, for counting me worthy of being a mentor. I really appreciate it. My background is in nursing. Well, like you saw in the beginning, I have a bachelor's degree in nursing. My first bachelor's degree was in mathematics and computer science. And then I went into nursing. I started off as a CNA from the lowest part of nursing anybody can imagine. And then from being a CNA, I went in to do my LVN, from LVN to my associate, from associates to my bachelor's to master's, and I'm currently pursuing my PhD. Please clap for me. Thank you. That is really encouraging. That's motivational. Thank you so much. So in research, I have served as an investigator during COVID. I served in several COVID studies that are in the market today. I've also served as a sub-investigator for a lot of rare disease trials, myasthenia gravis, systemic lupus erythematosus, a lot of diabetes nephropathy, and a bunch of other rare diseases. I have also been privileged to serve under Dr. Jewale, preparing the curriculum for the clinical community health workers research program. We're currently still undergoing the approval process. So if you want to be a community health worker, in addition to all the wonderful things that you are already, you are more than welcome to join us. I was an oncology certified nurse for 5 years with Baylor St. Luke's Medical Center. And then I taught over 500 students in the span of 5 years at Houston Community College. So it's been a pleasure. It's been a journey. And I am so thankful. And I look forward to meeting all of you on the other end of success. Thank you so much.
Thank you so much, Edith. And so last but certainly not least, Dr. Ogbo.
Thank you so much, Brittany. I don't know how I'm going to top that. I'm just going to try. No, I'm not going to try. Let us say it. I'm not going to try topping Miss Edith. But thank you all for being here. I want to appreciate you all for enlightening me and giving me hope that you all are octopuses. You know what that means, right? You don't know? Okay. So that means you are an extension to your brother, to your sister, to that neighbor who would not otherwise think that they can make it here. Don't take your 2 months and the next year for granted. Please, please. You are the salt and the light of this earth. And whether you know it or not, trust me, there's somebody watching you, somebody who probably has never spoken to you before, but seeing what you're doing from afar, and you are their mentor. So even as we are supposedly mentors for you, trust me, you're mentors to somebody else you might not even be aware of. So please don't take this honor and this privilege for granted. My name again is Nkechi Ogbo. I am a pharmacist by training. I know my thing is said 16, but I think I'm in my 18th year or 19th. I don't know. I know I look good, right? Can I say it? So my experience is in retail, hospital, geriatrics, anything you can imagine. And I actually had the privilege of working at Texas Children's Hospital. So when you guys mentioned your research there, I was one of those making chemos for them or writing like protocols for them before I came here. So I'm really privileged to have an extension of my former home here. I am also currently the health education and community engagement pharmacist. I call myself HACEP because that name is too long. But I work under Dr. Ajewale, anything she needs help with, logistics and whatnot. Yeah, so I like to have processes work together. But my other passions include financial literacy and nutrition, because we need a healthy body to be able to do whatever it is you want to do. And then also, no matter what you're making, you've got to be a good steward of whatever has been committed into your hands. So those are my 2 passions, in addition to everything that I do. I'm a mom of 3, really proud of that, and my other passion is singing. So forgive me in advance if I do without even knowing. Thank you.
Thank you so much for all the TSU Career Development Mentors for introducing yourself. Like I said, there are a few more who couldn't make it today, so we will get you in contact with them, in the weeks to come.
Thank you, guys. You all have done amazing today. The first announcement to let you guys know is the continued opportunity for community engagement and outreach. I want to say kudos to you all. Several of you already knocked out your 8 hours of community engagement and outreach for these 8 weeks. So very great job for you guys. During the fall and the spring semester, we do expect 8 hours of engagement between September 2025 and April 2026. We have a couple of priority events that are listed. You know, some of them are on a Saturday, some of them are on a Friday. Saturday, September 13th is going to be for prostate cancer. Friday, October 31st is breast cancer. Friday, January 30th is maternal child health. Saturday, April 18th is clinical research and engagement. So we're going to send the slides out. Brittany's going to share this with you guys so that you can sign up using the QR code or the Sign Up Genius link. For as many that has not already completed the survey, please, we can ask more. Go ahead and complete that survey. It is very critical because we need your genuine feedback to send back to NCI and NIH so we can ensure continued funding of our program. And of course, also program implementation, program improvement. So please go ahead and complete your survey if you've not already done so. When you walked in, you probably received a flyer at the door highlighting these 2 events. And for audience that are watching us online, feel free to scan that QR code. September is Prostate Cancer Awareness Month. October is Breast Cancer Awareness Month. So here at Texas Southern University, these are 2 major outreach opportunities for us. On Saturday, September 13th, feel free to join us in person or online. On Friday, October 31st, by God's grace, here on TSU campus, we will focus on breast cancer awareness. So scan the QR code, pre-register to join us, preferably in person, but obviously also available online. Okay, I'm excited, right? This is the second cohort of this program. And later on in the fall, we will open up recruitment for the next batch, right? We're going to do this again and again and again. So now you guys can officially be considered as CURED ambassadors, right? You want to pass the baton forward. You want to, help us in recruiting and engaging the next group of individuals that will partake in this same program. So when we are ready to start recruitment, we will be reaching out to you guys, sending the flyers out, and you guys can be that real life advocate to say, hey, I went through this program, I enjoyed it, and I will highly recommend my future colleagues to participate. So more information to come on this. Of course, we could not have done this event today, and not just the event, the entire CURED program, without the amazing support of great leaders. Please help me to appreciate all the C-Rep leaders. Many are not here. A few people are here. Dr. J from TSU, Dr. Ogbo, you've met her severally. Dr. Ogbo, we love you. We appreciate you. Dr. Juan Shisha, you are just amazing. Thank you so much for your support. And we are just very grateful for your dedication towards this program and towards the scholars. Brittany, I tell Brittany all the time, like, Brittany, you understand the assignment. She did just that. Brittany took ownership. She's truly invested in you guys and in ensuring your success. Brittany, we are very grateful for you. Please, a round of applause for Brittany. Thank you, Brittany, for all that you have done and all that you will continue to do with the program. Jasmine is Brittany's counterpart at Baylor College of Medicine. I'm not sure if she's online. Jasmine, if you are, we love you. We appreciate you. We understand you are not able to make it here today, but thank you for everything that you've done to support the program. The other person that you saw supporting, that the scholars saw supporting them for their presentation is Shamaze. So when everybody said that your presentations were great, these scholars were coached, right? During office hours, we ensured one-on-one coaching as much as possible. So Shamaze Box, she's probably watching us online. We definitely appreciate you. All the institutional leaders that you saw come through, from TSU and from Baylor, we are very grateful. Scholars, please help me to appreciate with a round of applause all your mentors. Mentors, research lab mentors, everyone that poured into the research experience of these scholars, we are indebted to you guys, and we are truly very grateful to all of you. And of course, to all our program staff. Cassie, she's right there. Thank you, Cassie. We appreciate you. Mark is there on Zoom. Edith, everyone just, pouring in, showing support. And for the AV Tech team, a lot of changes happened last minute. Constellation X, we do appreciate you dearly and sincerely. And with that, we can close it for today. And we look forward to working with you all again in the future. Have a wonderful afternoon. Thank you.